Vada Shubham Kurutvam Kalyanam Arogyam Dhanatam Vada Shatru Buddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute Shubham Kurutvam Kalyanam Arogyam Dhanatam Vada Shubham Kurutvam Kalyanam Arogyam Dhanatam Vada Shatru Buddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute. Shubham Kurutvam Kalyanam Arogyam Dhanatam Vada Shubham Kurutvam Kalyanam Arogyam Dhanatam Vada Shatru Buddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute. Shubham Kurutvam Kalyanam Arogyam Dhanatam Vada Shubham Kurutvam Kalyanam Arogyam Dhanatam Vada Shatru Buddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute.
I request G.V. Rao sir to say a few words. Good morning, everybody. I am Dr. G.V. Rao, representing AIG Hospital. On behalf of faculty staff of AIG Hospitals, a warm welcome to all the urologists here. I'm seeing the who is who of urology here. Thank you so much. Actually, it's I think Bipin has taken a lot of pains to organize this workshop, and all the credit of whatever positive things are happening, it goes to Bipin, and whatever negatives, whatever the drawbacks, actually, I am responsible for that. Actually, please. As GI surgeons, we seem to be sharing this common space between the urologists and the gastrointestinal surgeons. This is one area, again, we are competing with the gastroenterologists also. Unfortunately, actually, whenever we start doing some necrosectomy for walled up pancreatic necrosis, they keep telling us that your morbidity is very high. But the moment we start doing retroperitoneoscopy, the morbidity comes down dramatically. So this is one area we seem to be competing with gastroenterologists also and showing them that this is a terrific space to operate, and there are umpteen number of indications that are coming up even for us. And I think we just have to keep thinking about this thing so that we can expand the indications of retroperitoneoscopy. Initially, when Bipin came in here and he started talking about retroperitoneoscopy, all of us thought that is nothing much in this, but subsequently the work that has been done here shows volumes of what has been happening. My journey was associated basically with one endoscopist and one urologist. Actually, when I started my practice, actually, I was associated with Dr. Reddy, who was the gastroenterologist, and Dr. Mallikarjun, who was a urologist, actually. For the first 5 years of our practice, I think we traveled together. I think I learned more from the urologist than from any other specialty regarding minimally invasive surgery. So I literally thank these two people because we started our journey together. And when we started this actually hospital, it was a single specialty hospital. We realized that actually we were missing out a lot of things actually, and unless and until we work in tandem with other specialties, is not going to grow. That is where we started this AIG Hospitals here, and we have this like-minded people who joined us. Initially, we thought it would take almost about 5 to 10 years for us to stabilize here. But so many like-minded people joined here, full-time, salary. So we are able to kickstart this, and within no time we are able to break even. And in fact, we are planning to expand our hospital by another 500 beds in the next 1 year or so. The main attraction, actually, we have consultants who have joined us from far and wide, both across the country and also from Europe and US, basically because the amount of importance that is given to training and also to research in this hospital. I think some of you would have seen the animal lab here. Actually, this one of this kind of animal lab that we have here. This is the first of the thing on the private sector where we keep training surgeons and endoscopists in various newer innovative things. Whenever time permits, I think you can go around the hospital. Our staff will be more than glad to take care of that. And the biggest addition that we have been concentrating is on translational medicine. Initially, when we started investing in this, people thought it's a crazy idea that we are shifting all our clinical money into translational research. But the biggest thing that has happened was a lot of things that have erupted from the translational medicine have translated into realities, and we have a big edge over our counterparts, especially in GI medicine and GI surgery. But now we are expanding into the other specialties, and now we see cardiology, urology, neurology people also working with basic scientists to look into this translation research. I'm sure that you will having a feast of retroperitoneoscopy. Please enjoy this. Enjoy your stay in Hyderabad. Congratulations to the entire team at AIG Hospitals, actually Chandrasekhar, Raghavendra and other team. And within a short period of time, I think we got this recognition for DNB in urology, and we have 3 seats in urology right now. Kudos to the entire team. Actually, after gastroenterology, the highest number of cases are in the theater done by the urologists are done today. So there's a second. So thank you, Bipin, for stabilizing this department and also getting laurels to the department. And also within no time, we got this DNB. And I think the first batch of DNB students will get credits to the AIG Hospital. Thank you so much once again, and wishing you a great stay in Hyderabad.
Thank you very much, GV sir, for your kind words and encouraging words and upcoming upgradation of our hospital. So thank you, sir.
Now we will move to the next session, and Dr. Gaur was very interested to come, but unfortunately he has ill health and is joining on Zoom with us. May I invite the chairpersons, please? Dr. C. Mallikarjun, Dr. Mallikarjun Reddy, and Dr. Santosh Kumar.
There's always Santosham between two Mallikarjuns, isn't it?
So,
Well,
I think sir doesn't need any introduction. He's a legend in himself, and only one sentence for him. He's the father of retroperitoneoscopy.
I think good morning to everyone. The giants in this field were collected in the city of Hyderabad, and I feel so bad that I'm confined to the hospital bed. I thank the organizers for inviting me, and today I'm really, I'm the seventh heaven. So about retroperitoneoscopy, how to change the slide?
Yeah, you want me to put the presentation?
Yeah, about the presentation there.
Yeah.
Okay.
Can you sit this out?
Oh.
Yes.
Okay. Einstein said that imagination is far better than knowledge, because knowledge is limited while imagination circles around the globe. Now, I believe in that philosophy of Einstein, because according to our Vedanta philosophy, whatever you think is going to happen, but there is no time limit. Maybe tomorrow, maybe day after tomorrow. And also, whatever is doable is thinkable, and whatever is undoable is unthinkable.
They wanted full screen. You will have to do this.
Oh, yeah. Listen, very, very, very good. So now, I tell you a small,
you got it, sir. You got it. You can continue.
a small story. When I was in 4th standard in Bikaner, during the independence celebration in 1947, the teacher asked all the boys to get collected for celebration of the Independence Day in the stadium. Now, I thought there is going to be an extra class in the stadium. So like a fool, I took my books and the bag. This was the bag home stitched by my mother. Now, when I reached the stadium, the teacher was very angry. He said, everyone was asked to wear Gandhi cap. Where is your Gandhi cap? Well, I said, in the spur of the moment, I just got it converted into a Gandhi cap. Because at the time, I did not know what a Gandhi cap was. And I saw the boys wearing it. So this was an innovation at the age of 11. Now, I hated laparoscopies very bad, because at that time, there was nothing which we could have done except go inside, locate the testicle, come out, open up, and do the orchidopexy. So now, then who prompted me to take laparoscopy? I think it was none other than the great Dr. Ralph Clearman. And every year I used to go to Cleveland Clinic after the Bowes meeting. And it was in 1991, June, when I was there. I think the news was that Ralph Clearman has become the first in the world to perform a nephrectomy laparoscopically. I asked them how it was done because I had no knowledge at that time. They said he went to the front, refracted the colon, and that's how he did it. He took 11.5 hours. By the time I told those residents there in the Cleveland Clinic, well, this is not the right way to remove a kidney. He removed the kidney in 1 hour from the back. And you should be doing the same procedure laparoscopically. This will be. But the residents told me, nobody has ever done it. They tried to do it, but this has been shelved. They say that it won't be able to do it. I told them this for the moment, look, nothing is impossible in the world if you believe in the philosophy of Do Bhavam Tadvad. I told them next year when during my annual visit to the Cleveland Clinic, I'll show you boys how it should be done. Now, anyhow, I told them like this, but it was a tough task. A person is trying to climb Mount Everest without any training, without any knowledge of the surroundings. And still he has promised that he will do the job. Well, so the steps I took to get converted into laparoscopy while still in the USA was I to study. I didn't know what operative laparoscopy was at the time, how ignorant I was. I thought of buying the instruments, but I couldn't buy it. They were costing $20,000. While I had only $100 in my pocket. Then I took some basic lessons in laparoscopy by watching a general surgeon doing cholecystectomy. Then I returned in month of June 1991 and went into a meditative mode. I dreamt of doing an Indian rope trick. And during my 2 months of retreat, I got wiser. But I know that people could not visualize retroperitoneoscopy. During retroperitoneoscopy, the vision was poor because of there is no space, and also people have tried it but have failed. And I came to realize that there is a potential space in the retroperitoneum which has to be explored. And then came a patient with a large retroperitoneal cyst, giving me the cryptic message, So Tadbhavat. Now, kidney is just lifted up by the big cyst, retroperitoneal cyst. Now, if you get such a case, you put your scope, laparoscope, working ports, and you can easily remove the kidney. Then a few days later came a God-sent gift to me, a thin-built patient with a chronically impacted 4 centimeter long stone in the upper ureter with gross hydronephrosis. At the time, the only treatment possible was open up the stone. I told the patient, I'm going to open up, but by a small incision, by a special technique. The patient agreed. So this was the big stone in the left upper ureter. I must pay a tribute to my anesthetist, Dr. Padmini Pai, who was a trained gynecologist also. She was a great help to me during my first procedure because I was absolutely ignorant in doing laparoscopy. So the patient was, that patient was posted for the next day, and on the operation table, I thought that I am going to put my hands and make a big space. Then I thought, why not? Let the air do the job. I made a small balloon, put the balloon inside the retroperitoneum, inflated it till I could see the big bulge. And after that, I removed it, put a scope, and my God, it was a fantastic view. And I said, Eureka, Eureka. You could see the kidney, lower pole completely dissected. You should see the stone completely dissected. You can see the psoas muscle completely dissected. It was an absolutely great feeling. Thus, history in retroperitoneoscopic surgery was created by relatively ignorant laparoscopic surgeon on 24th September 1991. Now, why others had failed? I think it was my ignorance will help me. If you know that laparoscopy means, number one, varus vein. Number two, trocar. Number three, pneumoinsufflation. So people who have been doing laparoscopy, when they want to do retroperitoneoscopy, they think in the same way. And that's how they failed. Because this is not the right method. You have to create a space. Now, after we reported our first experience of retroperitoneoscopy, there was some concern about explosive rupture of the balloon and causing some damage. I am very grateful to Dr. Sanjay Kulkarni of Pune, who offered me to send my resident to his experimental lab, Dr. Dinesh Agarwal, went there and busted some 100 balloons and there was no damage. Now, our investment, the project was self-supported with no financial help from the institute. The institute said it was my personal matter. By the time we performed our first RFP procedure, our investment was zero, as the instruments were borrowed from the gynec department. Later, we got the basic instruments made from a local instrument maker for only 20,000 rupees. For the next 6 months, we continued to work with no monitor, no endocamera, no insufflate. So those days, I also presented a paper in the Urology meeting that this was like doing a barefoot. This is a barefoot surgery. No shoes to wear. So now, one of my residents, a smart boy, Dr. Patil, he said direct mission, he can do it, but he made a special spectacle. Those spectacles could hold the laparoscope, so my assistant did not have to hold it over my eyes. Yeah, but this was the luxury. This luxury I could not get because we had no money. And so then I wanted, well, there was no camera. So how could I tell the world? So I had to think of recording it, think of buying a monitor. Now, as the finances were very low, so I asked one of my gynec friend, Dr. Prashant Mangeshikar. He was a leading laparoscopic gynecologist. He gave me the idea that if I buy a spy camera, an Olympus laparoscopy connector, and a 2-in-1 IVA TV, I'll be able to record, demonstrate results. So the risky journey was taken by my son-in-law, Dr. Naresh Rao. He had just joined Bombay Hospital at that time. He went to Singapore and got these 3 devices. Of course, he had to pay some duty, but that was phenomenal. The global impact of this pioneering innovation, well, naturally there are so many guest lectures all over the world, when I met Raymond in Singapore for the World Congress End of Urology 1992, he just held his head with both the hands and said, "Oh my God, I thought of everything but a balloon." Professor Sigura in Winnipeg, Canadian Neurology meeting, after my talk, he came to me. He said, "Did he get it patented?" I didn't know what patent was at the time, and it was not done. Then the Royal College of Surgeons awarded me the Hunterian professorship. Our institute was kind enough not to throw me out because I was not making any money at that time. Now, in one of the AUA meeting in Orlando, one famous urologist, I'm forgetting his name, he met me and he said, "Hello, are you the balloon man?" I said, "Yes." So since then, I think I just called it I'm balloon man. So this is, ladies and gentlemen, I present to you the balloon man. Thank you.
Wonderful, sir, wonderful. I think I need to take some history along with you, Dr. Gaur. I think I was there in that meeting when you had demonstrated a retroperitoneoscopic nephrectomy in an ELSA meeting in 1995. That's the first time you demonstrated a nephrectomy outside the country, if I believe it. Am I right, sir?
Well, I think my memory is fading.
Sir, no problem. Because I was there at the time.
You are right.
Late Malcolm Copcoat of England and you were there in the ELSA meeting in 1995 at Singapore, and you demonstrated that. If I remember that picture, what you showed was that time's picture only on ELSA meeting of 1995. You did a retroperitoneoscopic nephrectomy at that point of time. And thank you very much, sir. You're talking on the anniversary of your invention. You know that? You invented on 24th of September 1991 and today is 25th September 2022. And you're talking about the balloon man who created it so many years ago. And it happens to be the one day late, that's all, sir. Nothing more than that. And I would at this point of time will tell you one more thing. This AIG is one of the, if how many of you remember the first clinical notes, natural orifice transluminal endoscopic surgery was done in AIG, and it is presented by Dr. Rao and Dr. Reddy at that point of time at the SAGES meeting. They did a transgastric endoscopic appendicectomy. Kudos to Dr. Rao who presented it, and half of the people didn't believe it, and later they had to believe it, that it was possible. So the first clinical notes in this world was done in this institute, that original institute of this place. Thank you very much, sir. Any more comments, please?
Thank you, sir. Thank you for this nostalgic presentation. I think a lot of us who probably would not see you very early when you were operating, I think this is something which we all need to look at, how you can think, how you can innovate, and if you believe in yourself, you should be able to do it, provided your thinking goes right. And now we are also lucky that we have so many mentors around, and then they would be able to guide us through. But thank you very much for this wonderful explanation of your...
Thank you very much for giving me a chance. While I'm just still on time to the bed. Thank you very much.
Thank you, sir. I think from my side, I personally feel Dr. God and Dr. Asopa. I think for urology in India, if there is any original, real contribution, it is from you two gentlemen. Thank you very much, sir.
Thank you.
Yeah, I think we'll call on Dr. Pranjal to speak on retroperitoneoscopic donor nephrectomy. I think Pranjal also doesn't need any introduction. He has got so many pioneering surgeries to his name. And then he is one of the most proficient exponents of retroperitoneoscopy. His surgeries we have watched many times, and he's one of the first to do laparoscopic donors, and apart from donors, the recipients. So he's now the dean of IKDRC. Yeah. So thank you, Pranjal, for being here. Then please.
Thank you so much for a very kind introduction. I'll just, it's my journey to retroperitoneoscopic surgery, and mainly it's in surgical audiences there. We'll just talk about various anomalies, vessels when we'll present. That was a question asked also during the time when I was operating the previous case. Thanks to the organizing committee for giving me this opportunity. The first donor nephrectomy done laparoscopically in 1995 by Ratner in at Maryland, and then after it has been picked up and it became the standard of care in most of the center. I saw Dr. Gill operating in a World Congress of Endourology, which was he was operating at Nadiad. The transmission was happening at Mumbai, and I think it was the breakthrough in my life. I saw him operating in a very small space, but very proficiently, and realized that this is the place where we can do a lot of work. And we started thinking about retroperitoneoscopic surgery in 2002, 2003. We could do some ureterolithotomy, and so by 2005 we realized that yes, it's a good operation because it avoids the handling of the bowel, spleen, pancreas, liver, etc. Like you retract the liver, you have a hematoma under surface, which is not considered as a grade 1 injury, but it is just neglected by most of the urologists. And if you can have some hematoma in a spleen, occasional case of splenectomy required, or on the left side nephrectomy or so. Some rare cases of an injury to the pancreas, etc. can occur, bowel contusions can occur, etc. So this is nothing, just it's a virgin area where you can work, and no damage to the intraperitoneal organs. It reduces the chance of immediate and late post-operative complications due to the injury to the viscera and peritoneum, as somebody has commented that by moving the left colon you have a more paralytic ileus or so. Since year 2005, we started doing retroperitoneoscopic living donor nephrectomy. When I asked Dr. Trivedi, who was our then director and nephrologist, that I would like to go for the retroperitoneoscopic donor nephrectomy, he looked at me, smiled, and then he looked at our blood bank officer, Dr. Aruna Manikar, and said that, Aruna, keep your blood bank ready. He wants to do the laparoscopic donor nephrectomy. So this is how he never said no to me, but he just warned me. I'll just go through the few salient features about it. We all know, we have seen now in the previous two surgeries that what are the port placements, so no more discussion into that. This is on the right side, which probably at the end of I said that this is the port which we put it for the endo-TA or endo-GIS stapler, and otherwise these three ports are there. This is around a finger breadth above the iliac crest, parallel to the psoas muscle, and you can apply the stapler. This was our innovation. There's the first at that time. If you see the papers in 1995 to 1997, the first 8 right side donor nephrectomy done by Clement et al. Ratner et al. And they found 3 grafts lost because of the venous complications. All were on right side donor nephrectomy. 3 grafts were lost. There were thrombosis. Out of these 3 graft loss, there were double renal vein on the right side, and they could not reconstruct it properly. And one that was a very small renal vein leading to the bleeding problem also. So I think it is very important to find out a good solution, and I didn't find any good solution in 10 years time since the laparoscopic surgery was invented. And then what we did is that we introduced this first port in the Petit's triangle, inferior Petit's triangle. You can see now then this is that there are 2 arteries right side, one is clipped, the other is to be clipped, and then we applied the endo-TA stapler. First time in the world we have demonstrated the effectiveness of endo-TA stapler to take the cuff of the inferior vena cava. We all know we apply the Satinsky clamp in open surgery, right side donor nephrectomy, and take about a 4 or 5 millimeter cuff of inferior vena cava, so that the recipient surgery is very smooth. And that same thing we can achieve by dissecting it out. Here it looks very long right renal vein, but like this is what is important, and that was early, and it's quite a large cuff, which we have demonstrated. Now you can see very broad vein, and there are multiple veins, two veins, they join together and make a one vein, and there is you can see here a one stapler is applied over here also. Then we can take the cuff of it completely. So then two renal veins are of a different caliber. We join one, you can apply it. And these are the two renal veins again. One is opening posteriorly, one is opening anteriorly, and there is an artery. So now after controlling the artery, we can take the same staple application, and you can see the common cuff of the inferior vena cava can be taken without compromising the lumen of the vein, and that gives a comfort level to the recipient surgeon to a great extent. And you can see here that this is anastomosis which has been carried out with the external iliac vein. So, and then this is the incisions which we standardize over a period of time, and through which we have carried out the most of the, because this incision has also not been described. In fact, after our publication, another publication came from Maryland group that they have started putting this port in a transperitoneal surgery. This port has been placed over here, so that the staple application is parallel to the inferior vena cava. So we identified it first that you can put the port posteriorly and you can have a parallel placement, and then subsequently they have changed their port placement to the right iliac fossa to get the appropriate length of the right renal vein. We published this way back in 2007, and this is our first publication related to the donor nephrectomy, how to get the inferior vena cava cuff. And also, like two renal veins are not a contraindication for retroperitoneoscopic right-sided donor nephrectomy. This was published in a journal of endourology, and many questions came from the email from the Western world that this is something you're doing heroic and maybe you can encounter complications, but fortunately we did not encounter many complications. Now there are anomalous vessels on the left side also, like here in this case the retroaortic renal vein draining into the common iliac vein, like a CT is clearly showing that thing. And you can take out this particular, like you can dissect out the iliac artery, common iliac artery, and this is the common iliac vein. It is seen better here where the renal vein is inserted. You just put a clip over here and take it out. Take out the clip also. So this is also this technique first time we have described in the world literature, though there are case reports, but the description of the technique of original research is very important. We found this useful to the public, and we can take the anomalous vessel even on the left side. More difficult cases, like you have a normal vena cava, and this is a duplication of inferior vena cava. The left renal vein opens into the inferior vena cava, both right side as well as left inferior vena cava also. And should we take the right kidney or should we take the left kidney? Since there is anomalous vessel here, and we decided that we go with the left kidney in this case, though the function was normal. Retroperitoneoscopic surgery, again, you can find a large lumbar vein, the left side inferior vena cava, and some connection there which is going somewhere, whether it's a lumbar vein or it is something else, we do not know. We just clamp this connection between the, you can see this is the renal vein on the left side, and we just put a clamp on that, bulldog clamp, and see that there is any congestion happening into the cava or not. Nothing happened into that, and then we applied and disconnected the left renal vein junction with the left side vena cava. And then subsequently you can see this is the division here, and the left renal vein here, this is a clip, the clip on the connection which was here with the left side cava, and you can see the connection with the right side cava, and you can take it out the graft with functions very nicely without any problem also. I think and subsequently BPN is having a series of 4 cases, and I think our group has presented the cases of a retroperitoneoscopic left donor nephrectomy with duplicated inferior vena cava also. Coming to the variations in the renal artery anatomy and retroperitoneoscopic living donor nephrectomy, like these are the cases where there is early division of the artery, and you can see the upper polar artery. It's often been sacrificed since it supplies about 8%, 10%, but we don't like to sacrifice anything because it's a very precious kidney, very precious nephron mass, and as far as possible, it is better to save it. This you can see, this is upper polar artery like that, and we just applied the single clip over here, and then we suture it, the stump. That is the new things which we developed it over a period of time. If you apply staple, definitely there will be upper polar artery which is separated out, and then it is difficult to do. You can see on a band surgery there is a separate opening of it, and we innovated that thing that you can suture the stump whether below the level of the clip or above the level of the clip also. Both the things which we have, unfortunately we didn't publish that, and we have done more than 50 such type of cases, and we got a 96% success rate. Yeah, you can see the post, it is easy to do the transplantation when there are, and you see the perfusion of the upper pole also. So it looks little blue here, but it was a very good perfuse. Coming to the next stage of multiple arteries, like right side two renal arteries, most of the people will not accept it, right? But we have accepted. Here you can see the anomalous lower pole vein, it drain into the lumbar vein, large lumbar vein also. Right, and this is draining that, and there is another main renal vein is over here, right, and so we decided that this is a good size, good caliber vein, and this can be sacrificed also. So this has been sacrificed here, and two renal arteries can be taken together, and then we have a bench dissection, and you can have an end to side or side to side anastomosis, depend on your choice, and you can go ahead with the transplant. Like this is what we have done. Our preference was end to side in this particular case. Go ahead with the transplant like that. This is also side to side anastomosis which we carried out. So two renal arteries, donor nephrectomies are not a problem, and so the transplant part is also like triple pantaloon also, three renal arteries, we have no problem in anastomosing. On bench, you can do the triple pantaloon, you can do the transplant also. What the few minutes back, Dr. Mallikarjun has asked me, like, what will you do when there is a pre-renal, pre-caval renal artery? This is the pre-caval renal artery, and this is the post-caval renal artery, and that is what exactly has been demonstrated here. This is the inferior vena cava and kidneys here. So we can take this artery and this artery also, and we have published this later on. Like right renal allograft with the main renal artery at upper pole and separate lower polar artery. Like they're quite a distance. Like you see that these arteries cannot be joined together, and then subsequently you have to do the separate anastomosis with the external iliac artery in this particular cases transplant. We published this also, retroperitoneoscopic right-sided donor nephrectomy with pre and post-caval renal arteries, and I think this has been brought up in a previous case discussion also. I think these are very old data, and I may not go. What is important is that when we do the right-side donor nephrectomy, the warm ischemia time is slightly higher, but not statistically significant. When single renal artery is there compared to the multiple renal arteries, that the warm ischemia time is slightly higher, and so in a right kidney also. However, as far as the EGFR is concerned, in a right or left kidney, there is no much difference with the 1 or more 2 minutes of the warm ischemia time. We had few donor complications also, like artery bleeding, venous bleeding, injury to the ureter by the cautery. That peritoneal injury is very frequent. We put a extra port transperitoneally and or put a clip on the peritoneum. Conversion to the open operation required mainly because of the bleeding, especially in early part. Lympho seal in a retroperitoneum, which was kept conservatively in all cases. And of course, sometime injury to the vena cava has also occurred, which require repair by the open operation. Then bleeding has occurred in those cases also. Retroperitoneoscopic living donor nephrectomy is feasible and safe. Its outcome of transplant with graft with anomalous vascular structure are not different than the graft having standard anatomy, and it is donor friendly. Thank you so much.
Thank you, Dr. Pranjal, for that excellent picture. You see those arteries which are poles apart, and your surgical skill actually compared to a normal urologist is poles apart. So what holds so simple for you is quite difficult for others. I don't know whether you remember one of the late 2000s, there's a transplant thing in USI, and you had chosen a topic of multiple renal veins for transplantation. I was supposed to speak on it, and the only literature I found was of Dr. Pranjal Bodhi, and I had to request him, and he generously gave that paper which he had anastomosed multiple veins separately. So most people will tie off the small veins, Dr. Pranjal will not. So he has, each one of them he has gone and transplanted. So that is your skills and that is your way of working. Thank you very much.
I have a question, Pranjal. In which case you will not think about doing the retroperitoneoscopy?
As far as the donor nephrectomy is concerned,
Of course.
if there is a previous history of a pyelolithotomy or something like that with some history of adhesions or so, I may not go. And second is,
with your vast experience, there would have been some cases where, no, I will not attempt retroperitoneoscopy, rather. I will do an open donor nephrectomy. Has it happened any time?
none.
The reason why, yeah, perfect, that's exactly, because I expected that sort of an answer, but the reason why, you're in a belt of an area where you do find a lot of stone disease operated by PCNLs, etc. So when you think a pre-PCNL, a PCNL done in the same kidney before, will be a contraindication or any difficulties which you encounter when you do a retroperitoneoscopic donor nephrectomy?
No, I think, but that should be done by experienced surgeon, not by the residents. That's the only thing which we will take care. The technical difference, if I have to explain, is just you put a first port, where there is a camera port, and then 5 mm port anteriorly, and then introduce your scissors and separate out sharply whatever the adhesions are there between the kidney and the retroperitoneum. So nothing happens then, and a pinpoint coagulation is required if it is bleeding from that place. Just separate out that, because it's a track only. Once you cut the track, kidney is free. It's very rare that you find a sticking, but if it is open nephrolithotomy made, pyelolithotomy, nephrolithotomy, there is a prolonged drain history like that, then everything is stuck in a different way. So PCNL in fact is a vardhan hai, rather than it is a contraindication. Not a
Right.
problem.
Do you have any difference in the way, you see, the initial part of retroperitoneoscopy way back, probably I would say sometimes in the late 90s, there's a lot of discussion which happened whether to keep a balloon before the gerotas, inside the gerotas. There was a lot of discussion happening inside the gerota. Why not inside the gerota? Why only outside the gerota? Why not inside the gerota? So do you have any preferences in some cases that I'll put it inside the gerota or something like that?
Yeah, I think as far as reference is concerned, as I mentioned, I learned the retroperitoneoscopic surgery from Dr. Giel's operating. And he clearly mentioned, I had an opportunity to hear him 3 times. Every time he did outside gerota spacia, outside gerota spacia, outside gerota spacia. And then I didn't think much of it. Why outside gerota spacia only? What happened accidentally, sometime we have opened the gerota spacia, and then we found that there is an injury to the peritoneum also, along with it. So it is preferable to do it outside gerota spacia to avoid injury to the peritoneum and then to make your life more miserable later on. So this is what the standard teaching by the great teachers.
Yeah,
And
that got
that's how
standardized
just,
later.
yeah,
Absolutely
that has
got
been standardized.
standardized.
Nothing else. I didn't put my brain much inside. Somebody who experienced like Gill who is teaching us, then nothing else to be done.
No, it was there. It was there. Initial days, there were people who were putting it inside because they were looking at dissection of the kidney already happening. You do it once, even the whole kidney will be dissected away. The whole fat will be separated away.
Correct.
So that's the reason why I asked this.
Correct.
But anyway, great lecture.
Thank you.
And a vast experience is seen in the wisdom of your answer itself. Thank you very much, Pranjal. Thank you.
So it's a bit early for lunch, so we will squeeze in one more lecture. Dr. Krishna Prasad will be speaking on retroperitoneoscopy versus laparoscopy. To complement but not to compete.
Right, while that's loading, it's very difficult to outdo your teacher. especially when his N is 937 and your N is only 100. So it's going to be a while. Is this loading? Also, this was supposed to be a concluding talk, so it's prepared as a concluding talk, and Bipin has pushed me onto the stage before the conclusion, so we'll try to do justice to that also. Right, so I was given this opportunity by Dr. Bipin, and thanks for the rest of the organizers to allow me to present this little lecture where he called me up and gave me this unenviable task of asking me to compare and at least show that retroperitoneoscopy does not compete but should complement the transperitoneal skills of a surgeon. And this is how transperitoneal is. It takes such a long time to get to wherever you want to do. So it's like it's waiting forever to get to the area of interest. So we're getting there. And like we saw in the morning, it's quite quick getting to the area of interest in these in the retroperitoneoscopic approach. So let's get on without more deliberations on this. Okay, right. So to complement and not to compete. Fine. So medicine is an art, and while I was, looking through so many things online, I found this particular painting. What happened? Yeah, by this medical student, and I always wondered whether medicine is what we always have been telling is art and not a science.
The slides are not coming, please. We need the slides.
Okay.
Yeah.
Shall I go back? Now on. All right. Fine. So I was saying a drawing by a medical student, and we always wonder whether what we practice on our day-to-day basis, we forget it being, science. It's more of an art after a particular point of time, especially in the hands of people like Dr. Gaur, who have made innovations, or Dr. Pranjal, who's had the numbers. And my thought process when somebody asked me to compare this was, I know Dr. Jamal is having a nice smile down there. I won't go into the details of these motorcycles, but pretty much transperitoneal is like the left-hand motorcycle, and the retroperitoneal is the right-hand motorcycle. What exactly is the transperitoneal motorcycle? It's something that is ridden in the upright position. We're all aware of this. We've been riding motorcycles since we were in our college days, and so we're more attuned to sitting up and riding on a bike. Whereas I'm sure the KTM and Dukes, which came in much later in the 2000s, you would have that lean-in position. Do I have a pointer here somewhere? Yeah, right. So you have a lean-in position, which is quite something which is unnatural. But when I was looking at buying these two bikes, I realized that, okay, this one has so much more power than this. And then it gets you to your location much faster. So just like retroperitoneum, you reach your organ of interest much faster than, say, you would do it with the transperitoneal technique. But that's where the advantage, I think, ends. The range is much lesser when you compare it to, say, the transperitoneal motorcycle. And when you get into trouble, obviously those of us who ride motorcycles know that an alloy wheel which brakes gives you much more trouble than, say, a motorcycle which we always have had since our college days with this traditional spoke wheels. And coming from Bangalore, I need a motorcycle which can give me the ability to jump over bumps because of the kind of ground clearance this motorcycle leaves. So let's leave all the motorcycles here and we'll stop all comparisons, but just look at this. So broadly, you can compare retro and trans in these parameters. So familiarity, like what I told you earlier, the access to the region of interest, the range of movements and procedures which are possible, and the ability to tackle complications. So while I was looking at this, and I was thinking which surgery should we take up to look at data and see whether we can describe all these parameters with the data which is available in that. I think the donor surgery, or the retroperitoneal and the transperitoneal donor nephrectomy, is by and large standardized, rather than when you look at the individualistic nature which can occur when you're doing a partial nephrectomy, or say you're doing a pyeloplasty. Barring the number of vessels, more or less, most of us are able to do the donor surgery with probably the same steps. So we can compare it there. And instead of picking up data from what is there in literature, I just decided to take our own data and look at what happens when we do trans versus retro. And somehow I'm uniquely positioned to compare this simply because I have one institution where my boss performs all the surgeries transperitoneal, so there's no selection bias, and I perform all my surgeries retroperitoneal, the donors. So we have two sets of groups which are already evenly matched. It's a small, we just looked at this bit of time frame, barring the 1 year of COVID. We ended up with N of 89, with 49 surgeries being done retroperitoneally and 40 being trans. So let's go back to the two parameters I described. If familiarity is what gets you easily to the area of interest, then obviously trans should give you better timings. You should be able to finish it faster and compared to, say, the retroperitoneal surgeon. So was that so? So when you look at overall operative times, hardly any different. When you look at the overall pneumoperitoneum times, which I mean to say that there's active pneumo and the surgeon is performing surgeries and, you know, trying to achieve some goals, there's hardly any difference. So this thing about, say, transperitoneal being more familiar than the retroperitoneum is thrown out of the window. It's definitely equivalent in terms of familiarity. Depends on how well versed you are with the retroperitoneal space. Of course, we found that there was some marginally larger loss of blood in the lymph in the transperitoneal group. This is an interesting bit of data which came as a result of this. We need to probably follow this up more. And what I saw was the recipient seemed to have a marginally better GFR at the end of 30 days. And in the retroperitoneal group, the donor seemed to have a poorer GFR at the end of 30 days. Yet to find some data, something like this to and especially when we get our larger numbers, to have a look and see whether this really turns out to be significant or not. Moving on to the two other parameters, which means the range of movements which is possible and the ability to tackle complications. So if we look at these two things, we believe that at least that in the transperitoneal you should be able to get a grip on your complications rather than to say something which is done retroperitoneally. But is this truly borne out by data? So when we had a look at this, we plotted our star plot here, and that's, forget about all these. Let's look at, say, the injuries which are possible during the surgery. So while it looks like the retroperitoneal group had a slightly larger number of injuries, they were insignificant. But what I want you to understand here is, what are these injuries? So predominantly anything which was injury to the peritoneum anteriorly, we classified as visceral injuries. So keeping that in mind, this is when the numbers slightly went larger. If you remove all the peritoneal injuries, then the star plot for the retroperitoneal group falls well within the star plot for the transperitoneal group. However, none of this is significant. There was also a discussion on whether there is a delay in the starting the oral feeds earlier on in the presentation, and we looked at that too, and really there was not much difference between both these groups in terms of initiation of feeds, and that's interesting. So very low warm ischemia time compared to, see, the the transperitoneal group. Not going to look at the rest because pretty much the same. And again, we found that much lesser pain score when you compare it to the transperitoneal group. So overall, really nothing much to say. If you look at our own data and all the rest of the data of donors published, forget about each of these endpoints. All you need to do is look at this last column there, and if you add up, it is 7 for retroperitoneal versus 6 for the transperitoneal group. So is it always advantage 7-6 retroperitoneum? I don't think so. I mean, it just depends on what kind of a surgeon you are. I mean, it's a very, very marginal difference if you compare 6 points against the transperitoneal group versus only 7 points for the retroperitoneal group. So this is about a series of cases which are done, and you try to get some statistical analysis out of that. Let's look at unique situations. So I'm just going to present to you one unique situation where retro may have an advantage over the transperitoneal technique. So one case, one example, 42-year-old female with stone disease. So we did a PCNL, upper pole supracostal puncture, complete stone clearance, the usual PCN ureteric stent placement. Third post-operative day, she becomes breathless. Ultrasound reveals significant pleural effusion. We did a thoracocentesis, and she was asymptomatic after that. And on day 5, we removed the PCN. About 2 days later, she becomes breathless again. And this time we ended up putting in an ICD. And from then on, she continued to put out about a liter of fluid from her ICD every day. So, pretty obvious what it looks like when we do a contrast CT. So that was the region of puncture. And there you can see the track going all the way into the pleura. And this lady had a nephropleural fistula. And obviously the ICD just being there was sucking out all the fluid, because of the negative pressure. So what were the options for us at this point of time? You look at the textbook and it says, okay, you do the regular things. She had a stent, she had a Foley, she had an ICD. What next? You put in probably a percutaneous tube and see if you can drain out all the fluid, the urine from the kidney. But somehow all these complications, I'm sure as your experience, is borne out, always happens to the most important people and the most difficult patients. So you had one, state level minister breathing down your neck saying, we don't want to do anything else. And the patient says, no, I don't want a percutaneous tube, do anything else. So what is it that we did? So you're pretty much familiar with this anatomy since morning. I'm not going to go there. So I went into retroperitoneally. So that's the abdominal wall end. That's the kidney. And after we instilled some contrast into the, methylene blue into the PCS, you can see the track there. On the right hand side of your screen is the pleura. I'll zoom in a bit, you can even see the pleural opening there. And that was the track going supracostally through the pleura into the retroperitoneum and into the superior pole of the kidney. And that's the ragged end of the pleura. You can see that little bit of blood which is suctioned off into the pleura vents. There are movements in the pleural cavity. Yep, there. So what did we do after that? So I just ended up suturing the fistulous end of the track on the diaphragmatic end with 4-0 Stratofix sutures, closing that end, and then we sutured off the track from the kidney with a 2-0 Stratofix suture there on that side. So that pretty much solved our problem then, retroperitoneal drain, and she did well. About 2 months later, we repeated the contrast CT, nothing else there. So this is a unique example where you can use your retroperitoneal skills to manage certain situations. So medicine is an art. I started by describing this, and then during this application of this art, I think it's not just using the finest science and technology available to us. It is the kind of knowledge and skills which we develop over the years, which define the character of a physician and how much care we can give to our patients. So I think I'm a retroperitoneal artist thanks to my teachers, but the final answer is whether we are going to compete or complement does not hold true. I believe you need to have adequate skill set on both sides, both transperitoneal and retroperitoneal, to provide the best care to your patient. So it's a skill definitely worth developing. Thank you for the opportunity. And if you want to know the question, I did buy both the motorcycles, so I know both trans and retroperitoneal. So thank you so much.
The two groups you showed, they were they matched?
I have that separately.
Yeah,
I know Pandey, you're interested, so it was all matched.
Second point is, I think 500-600 ml of blood loss is a little too much for Edith. Was that accurately measured?
So, for the sake of calculation, there are two ways we did it. In our hospital, we tend to weigh the mops, but then that was we decided that was not a very crude, it was a crude way to do it. So they would measure the output there at the suction end, and obviously during retroperitoneal, we were using all that fluid to create the retroperitoneum. So there was actually a significant mismatch. If you see there, go back and see, half that fluid was a bit of fluid which was used, about 400-500 ml, which is used to create the retroperitoneum space initially. So that is an issue there.
I don't know if you're allowed questions, but I'd say if you looked at your matching of the lab versus this thing, there are a few things. One is when you send it for publication, the question that will be raised is the blood loss and the transfusion rates. Extremely unbelievable as far as lab donors are concerned, because literally we are having nearly 0% blood transfusions in.
So we didn't have any transfusions.
I thought there's a 5 thing on it.
No, I'll show you. There were no transfusions.
There's some conversion also was written.
There was conversion. So this again we included all cases were included. So none of them were excluded. So what happens is we included even those where we converted and we put them into the analysis. So we didn't want to take away all that data and say we didn't do anything. No conversions at all. So they're there just to show that yes, we did conversions for some of them.
Okay, so I think what we take back is we should be well versed of both the technique as urologists, transperitoneal laparoscopy as well as retroperitoneal laparoscopy. There are some definite indication where one technique has edge over the other in particular situations. So
yeah, transfusion rate 0 in retro and 5% in trans. So that's probably 2 cases, I would say.
Heaven. Prasad, it's a good presentation. I just said like what the inference what you gave as both are complementary or both you need to know. Majority of the times, the problem in any scopy, whether it's retroperitoneoscopy or a transperitoneal scopy, is a complication resulting in because of an inadventure which will happen in your hands, or a non-progress of a step or a progress of the surgery because of a disease process which exists. So in both these cases, whether it is retro or trans, it doesn't make any difference. You are in a soup, you are in a soup. So I think, as you said, the thing which is going to happen whether you do it in a retroperitoneoscopy or a transperitoneal. A venous injury can happen in retroperitoneoscopy or a transperitoneoscopy. An inflamed kidney which is stuck to the pleura is common whether you do a retroperitoneoscopy or a transperitoneoscopy. So the approach per se will not make anything easier unless we are confident about the basic principles of the way we need to do it in either the way. That's what my feeling is. What is your comment on that?
So if you're looking at pathology, that's why I chose the donors particularly. But if you're looking at pathology, which means to say you're doing a radical or you're doing a partial nephrectomy, if you look at all the meta-analysis, they're pretty much the same. There's no difference between trans and retro. The only place where they have actually, if you're doing a trans and a retro pyeloplasty, it has been shown that there are far more conversions when you're doing a retroperitoneal pyeloplasty than when you're doing a trans. But that's not significant, it's just more. So, but if you come down to all the other ablative surgeries, whether it is a partial or whether it's a radical, it's pretty much the same whether you do it trans or retro. It's just a question of convenience. There may be some conditions where you feel doing it retro is far more easier for you.
So I think the take home message really is that these two are complementary. If you want to offer a full bouquet of approaches to renal surgery, you should be able to know both of them. I think if you can do both of them, I think retroperitoneal is more patient friendly for sure. And there's good literature support of this, especially in donor nephrectomy. There are situations where donor nephrectomy is contraindicated, and these are the ones where you should be doing transperitoneal nephrectomy so that you can minimize your use of open surgery. Otherwise, I think your indications for retro for trans would be an absolute indication would be a previous flank scar. Otherwise, very large kidney, perhaps obvious XPN kidneys. These would be the ones where you might prefer transperitoneal. Otherwise, I think if possible, retro, if not trans. I think that should be the message.
I think that's very correct. Thank you, Dr. Krishna Prasad. That's a very nice presentation. Maybe invite Dr. Rishi Nair to present his talk on robotic retroperitoneoscopic partial nephrectomy. Dr. Rishi, please.
Well, thank you, Dr. Bipin and the entire AIG team for having me here in this program. I was given the task of talking about partial nephrectomy through the retroperitoneal route. As we all know that partial nephrectomy is one of the most difficult or the challenging procedure that a urologist performs. Generally what is used is what everybody feels is that the transperitoneal route gives you more space and the ease of doing a laparoscopy would be much more important for doing a procedure like a partial nephrectomy. But there are some indications, there are some locations of the tumor where a retroperitoneoscopic approach may actually score over a transperitoneal approach, like in the posterior tumors, the tumors which are near the hilum and posteriorly located. In those kind of a tumor, the retroperitoneoscopic approach may actually be beneficial. And in those kind of a tumors, we actually prefer doing a retroperitoneoscopy. In all other kinds of tumors, we would do a standard transperitoneal approach. So before we go to the video of the procedure, actually, we have been discussing this since the morning, but I would just like to highlight the peculiarities of the approach. There is a limited scope for changing or tailoring the port position in the retroperitoneoscopic approach, as we had discussed in the morning also. But what we do in partial nephrectomy is sometimes if the tumor is at the lower pole, we would shift these ports further lower down. We'll not make the incisions close to the ribs. Rather, we will go a little bit further down towards the iliac crest, so that the tumor is not facing directly. We are not too close to the tumor while we are operating. The viewing angle, one should also realize in a retroperitoneoscopic approach, is somewhat little oblique compared to a dead lateral view that we get from a transperitoneal approach. So we should keep this in mind when we are operating, so that the orientation about the tumor remains appropriate. As I said, the panoramic view is not available in a retroperitoneoscopic approach, and if particularly at the lower pole, the tumor would be facing right into the camera of the surgeon, and the ports also, the working arms also are not that much inside. So therefore, the maneuverability also one has to be aware about that. The robotic arms, the distal 5 centimeter or so is what is important. So the working is limited. Then comes the working length, leverage, and excursion of instruments. In a transperitoneal approach, there is a 1:1 leverage, with the center of the instrument being fixed at the skin level or the muscle level. Whereas if we end up using the same instrument for the retroperitoneoscopy, this leverage goes away. So therefore, ideally speaking, we should be doing retroperitoneoscopic surgery using the smaller length of instruments. But because of the cost constraints, usually we end up using the same instruments, and therefore this leverage goes away, and doing retroperitoneoscopy becomes more cumbersome and less ergonomic. Because of the port position, particularly the camera port and the medial port, they end up being placed at a higher space. So therefore, the one arm of the surgeon is a little bit vertically oriented, whereas the other arm is parallel to the ground. The benefit that the retroperitoneoscopic approach gives is the direct and rapid arterial access, which is important in a case of a partial nephrectomy. So therefore, again, in places where we want to dissect the arterial vasculature well, the retroperitoneoscopic approach would tend to score over the transperitoneal approach. As I said, we would do cases like this where the tumor is located at the middle or the lower pole. In those kind of cases, we would do a retroperitoneal approach. Now, why the robotic platform? Robotic platform because retroperitoneoscopic approach is a little bit ergonomically difficult.
So therefore, in challenging kind of surgery, robot scores over the standard laparoscopy because the ease of maneuvering is better with the robotic instruments compared to the standard laparoscopic approach. The use of the fourth arm definitely provides fixity to the kidney and the tumor, and therefore we are able to work better. Whereas if the kidney is moving around, then cutting and suturing all becomes a little bit more difficult. The position is the same. We generally put bolster also apart from breaking the table. And this is the port position you will see. What happens is to put the medialmost port, we need more space, and therefore for the initial part we would use the laparoscopy and push the peritoneum further down so as to create space for the fourth port. For the third port, generally we do not need to mobilize the retroperitoneum as much. The balloon dissection itself suffices, whereas for the fourth port and the assistant port, some mobilization of the peritoneum may be needed. And what we use is the balloon port for the camera port, and we would make it as a hybrid port. The robotic port would be inserted through this port, a port-in port would be created, and then this would be used as the camera port. So this was the case. And we proceed with the retroperitoneal dissection, and within no time we would be at the renal hilum. So in this case there were two renal arteries. This is the first one coming into view, and just superior to that there is another renal artery which was dissected. The tumor itself was centrally located at the mid pole, so therefore both the arteries were looped and lifted up, and would put the bulldog clamp on both the arteries. If it is only a polar nephrectomy that is required, then maybe we could choose to do a selective arterial clamping. So after that, we would need some renal mobilization and opening of the aortas. If the tumor is somewhat anteriorly located, we would rotate the kidney down. The steps of the partial nephrectomy are subsequently the same as we go through the transperitoneal approach. Only the ultrasound localization and markings of the tumor would be done. So in this case, the tumor was going reaching up to the sinus area. So after marking it, we started doing the splicing of the kidney from the inferior aspect. Here you see the bulldog clamps being applied. Both the arteries would be clamped, and now we start the splicing. Now here if you see with the pull of the robotic arm, actually the tumor was coming out on its own, which I didn't like, so I went above the tumor. I wanted to take a good margin of the normal in parenchyma, so I went retrograde approach, coming from above down. So a good margin was taken all around, and you can see the sinus fat also coming there. The venous clamp is generally not required, particularly on the left side. Sometimes on the right side, we would put a clamp on the vein also. After that, the standard technique of renal is used. The inner layer is done with we use the 3OV lock suture. And once the inner layer is done, unless there is a specific apprehension that the bleeding may not have been complete, we generally do the early declamping. What happens is in the retroperitoneal space, there is not much space. So if there is a lot of bleeding, then the space generally tends to get filled up rapidly. So the suction should be good. And simultaneously, the insufflator has to be a high flow insufflator to keep the space distended. So now after this first pass, the bleeding was more or less controlled. Rest what is remains is doing the second layer. Sometimes we have even stopped doing this second layer also. So what I generally do is I keep the clips on both the sides so that there is no tearing of the renal parenchyma when we pull on the suture. So the clips stay on both the sides. This is obviously a video has been fast tuned by 2.5 times. Overall, the warm ischemia time was still about just 9 or 10 minutes. And then the aortas may or may not be closed because this is of course only a retroperitoneal space. We still close it because if sometimes there is a small hematoma, it gets tamponade because of closure of the aortas. And then we bag the specimen. So this is the final post-op picture. The specimen was removed from the lower assistant port from where we had placed the air seal. This is another case which was done purely laparoscopically, and this is actually a model that we had used for during one of our projects. In this model, if you see, based on this model, we decided that we would be doing a super selective kind of clamping in this particular patient. There were these two small arterial branches which were directly going into the tumor and were supplying the tumor. So based on this CT and model, we decided for the retroperitoneoscopic approach. This was done with the pure laparoscopic instruments. Okay. So this is the main renal artery here, and it is dividing into two main branches. And the central main artery was further giving two smaller branches, which we had thought we would be doing the super selective approach. So after taking control of the main hilum, we again marked the tumor, and then went into this deeper hilar dissection. This deeper dissection of the arterial tree comes better from the retroperitoneoscopic approach than the transperitoneal approach. So whenever one wants to do such kind of a super selective arterial dissection, probably retroperitoneoscopy is the approach to be used. So this is the second smaller arterial twig. This would also be ligated. And after doing this, this is the completed procedure you can see. So just to conclude, the benefits of retroperitoneoscopy are obviously it avoids the breach of peritoneum, and therefore no abdominal viscera is at any kind of a risk or post-op complications. Though it seems a technically more demanding, use of the robot eases it out further, and the middle location is best suited for the beginners to try and do this. And what I would recommend is, particularly in cases where if you want to do a super selective clamping of the arteries, then in those particular situations, maybe try and use this retroperitoneoscopic approach. Thank you very much.
Thank you, Dr. Rishi. It's a very nice presentation. Only I think is it. Do you get enough space for the 5 ports in a robotic approach? And in any circumstances, you found that maneuvering the instruments into the limited space, is it a space constraint, particularly when doing the renal.
Yeah, so if one wants to place the fourth robotic arm, then generally the retroperitoneum has to be moved away with the initial laparoscopic approach. But if you use only the 3 robotic arms, then it ends up being a standard retroperitoneoscopic port placement, and generally it is doesn't require the balloon dilatation itself pushes the peritoneum sufficiently.
Do you find that the suturing is far more easier with the robot rather than you without?
Yes, definitely. Particularly if you are doing the upper pole tumors and the slice of the kidney is such that the angulation you require to be suturing at nearly a 90-degree angle to what you have entered into the retroperitoneum. In those spaces, the dexterity of the robotic instrument helps. But for the middle pole and lower pole tumors, even a standard laparoscopy would be good enough.
I think the 4th port and all will come in with an XI. With an X, it would be very difficult because the arms are very close and they tend to clash. The XI, you have all the options to rotate the arms out. So if you are trying to do it with the X, then it's much of a clash and it's not going to be easy.
So fourth arm is not always necessary. What I see is whenever you want to, the kidney is mobile, when you have rotated the entire kidney, like in retroperitoneoscopic approach, when the tumor is anterior, then you will have to mobilize the entire kidney. So when it becomes mobile, then the fourth arm just holds up the tumor up and it stabilizes the kidney while you cut or suture. So in those kind of a cases, the fourth arm would help. But otherwise, you do not require a fourth arm most of the times.
It's a nice demonstration, Rishi. So which model of robot were you using and how did you dock it?
Sir, we are using XI. The robot comes from the shoulder end and from the side docking. And actually the central boom allows all the arms to rotate in 180 degree.
Do you think this would be possible with any model apart from the XI?
Yes, even SI should be able to do it. Only thing is the rotation of the arms would not be available. The targeting is also probably not available. Only thing is the robot has to come in that oblique by itself.
Oblique because of the pedals, it would not come particularly close to the table, so you might have difficulty in docking. That's what I feel.
Yeah. So
are you aware of literature of the use of SI for retro partials?
Sorry.
Are you aware of literature for the use of SI robot for retro partial nephrectomy?
SI, I'm not aware of that. Not many people are using retroperitoneoscopy, but using the SI robot specifically, I'm not aware of that. If you see in this picture here, this is the robot. It comes direct. The alignment of the robot is parallel to the OT table, and the arms can then be rotated or targeted depending upon where the target location is. Oh, no, sorry.
I think the question raised by Jamal was, is it easy to do partial retroperitoneoscopically with SI? Am I right? It is possible, but it's not very such an easy thing, because there is some amount of clashing and you require to restrain your movement of the arm significantly, and there is some amount of hitting of the arms which is quite commonly seen. You're blessed regarding XI.
Yeah, hi, Dr. Rishi. Just wanted to ask you that in case of anterior hilar one, would you venture into retroperitoneoscopy or would you choose transperitoneal approach?
As I said, we generally tend to select our patients. Most of our patients that we do retroperitoneoscopy are posteriorly located or laterally located. For most anterior tumors, I would still prefer doing a transperitoneal approach, particularly when I'm not planning to do a super selective. Super selective approach should be decided before the surgery based on the CT and imaging.
But I think if it is an anterior based tumor also, a retroperitoneoscopic can be done easily.
In upper pole?
No, if it is anterior based tumor.
Yes, it can be done. It can be done. But what I'm saying is, unless It is just a matter of fact that it gives you more space anteriorly. So
There is
we
a
just
definite
select out
advantage
our
of
patient. That's the only-
based tumor.
It can be done. It can be done. I am not saying that anterior tumors cannot be done retroperitoneoscopically. You just need to flip the kidney. If it is a lower pole tumor, it would come to the space available would be much less. You will be looking directly over to the tumor. So if you are tuned to doing surgery, seeing close to the tumor, then it's fine. You just need to remain oriented. Sometimes what happens is the surgeon may lose orientation when the vision is always close by to the tumor. So for the beginners, choose a tumor which is at the mid pole of the kidney, and then afterwards, once you are past your learning curve, you can do any kind of a tumor.
Probably in retro, the only time where I would not choose is something which is very medially located, lower pole, hilar or even anything else can be, you can drop the whole kidney down and still manage to do it. Even the anterior ones, you can drop it down and do it. Truly, I would say medially placed hilar or medially placed lower pole, it becomes very difficult in suturing. But of course, with the robot here now, even that becomes a little easy. Maneuvering the kidney to get around the tumor becomes difficult then. Even if you manage to maybe mobilize the entire kidney, how are we going to get that curve with it's running off medially? That becomes a challenge. Then that's probably more easier transperitoneally.
Yes. So what happens in transperitoneal, you can maneuver the kidney. Dr. Mallikarjun has demonstrated that you can even rotate the kidney to orient it and suture it. So, but in retroperitoneoscopy, that kind of a space is not available to maneuver the kidney as much.
And then in partial, it will be 4-port or it will be standard 3-port?
3-port is sufficient. 4-port is, I would use only in where the kidney mobilization is required and just to stabilize the kidney during cutting and suturing. In those cases, I would put a 4th. In this case that I had shown, this was close to the hilum. So the 4th port was used.
Thank you, Dr. Rishi, for your presentation. We'll close this session.
Thank you, sir.
Thank you, Dr. Rishi Nair and Krishna Prasad sir, for rescheduling your lecture timings, and thank you, chairpersons, for nice interactive session. May I invite Dr. Santosh Kumar sir, Dr. M. Gopi Chand, and Dr. A. V. Ravi Kumar to chair the session.
We're not going to irrigate, but let's set here. Table down, please. Let me start with the building. Who is going to position the table? Vipin?
Very good morning. So, can we have a description of the second case also? For the theatre or?
Good. Now just make the break less.
Good morning, everyone. This patient is Mrs. X, 53 years, presented with right loin pain for 1 year. Increased frequency of urination for last 9 months. 1 year back, she underwent left URCL plus disease stenting for left bruised oculi. Since then, she complained of intermittent colicky pain in right loin region. She also complained of intermittent increased diurnal frequency of urination for last 9 months, for which she consulted doctor and diagnosed to have type 2 diabetes mellitus CKD, stage 1. There is no history of obstructive bloods, incontinence, hematuria, pyorrhea, high-grade fever, Silsenheimer. Bowel habit and sleep is normal. Patient presented to AIG 1 month ago and after evaluation diagnosed to have hypertension in right non-functioning kidney. On examination, her BMI is 31 kg per meter square, BP is 130/80, other system examination normal. NCCT KOB cross right hydrogenesis, which removed calcification in thinned out renal parenchyma. DTP scan was done and no tracer uptake in right kidney. Here is the video of the CT scan.
You play that video?
Yes, sir. Thank you, sir. Over to Raghavendra, sir.
So I guess we are the team of only retroperitoneal surgeons. Nearly they do 100% of their work retroperitoneally. But Dr. Pranjal, any specific, I think we talked about the open surgical scar for the kidney. If it is there, probably in the retroperitoneum you would not do. Is there anything else on a kidney which you would not do retroperitoneally?
Yes, I think many cases we don't like reconstructive surgery, pyeloplasty, would prefer to have an anterior approach rather than the posterior approach, especially when crossing vessels are there. So will not do even in elective cases. We all go transperitoneally. Any tumor size is more than 8-9 centimeter or so, we'll prefer transperitoneally because the space is limited, especially if it is a exophytic type of large tumor. Chances of the injury to the tumor or maybe the surrounding structure is likely to be happening. If it is a case of XGPN or so, sometime, yes, we have done the retroperitoneoscopic surgery, but conversion rate is higher. We explain to the patient in those cases. So these are the few contraindications. ADPKD kidney, we have done it, and we have done morcellation of the kidney also. So large ADPKD, but like if it is to be done bilateral simultaneously, if it is planned, then probably the maybe transperitoneal is far better because you don't have to put a separate incisions for the same thing. Like you use the same ports and the midline ports are used in those cases, then it is fine. So these are the few cases where we would like to go principally transperitoneally. Otherwise, majority of the kidney surgeries and adrenal surgeries and upper ureteric surgeries can be done by the retroperitoneoscopic surgery, which includes both in adult and in pediatric patients also. Like few cases of retrocaval ureter, we have done it retroperitoneoscopically. All the donor nephrectomies and adrenalectomies, by and large up to 6-7 centimeter size tumors, we do the retroperitoneoscopically. That's what the indications and contraindications by and large.
And we had extensive discussion on the port placements. I guess you're all from the same school.
Yes.
Is there any difference?
I didn't listen much, but just I would like to brief about it. So the points of reliable points are the iliac crest and the anterior superior iliac spine, and the erector spinae muscle. The non-reliable points are 12th rib, right? So typically people say that at the tip of the 12th rib we put the first incision or so, but sometimes the 12th rib is very short, or sometimes it is long, or even sometimes it is absent also. So we have to be careful, and often nowadays hardly we get an X-ray done. Mostly it is a CT done. So you don't know where is the 12th rib or it is the 11th rib or so. That is important point to be remembered. Second is once you give the position, then we mark it rather than we mark prior to the surgery without giving position. So everything is after the position only. So that will give you the, like here, do we have the camera here so I can show like
we are seeing the surface view, just too bright, yeah.
Yeah, just switch it off. Do we have the laparoscope ready? Like, yes, just a minute. Yeah, just make it on. Yes, it's easier.
Yeah, endo view is good, so we can keep the endo view. The other one you can probably
right.
keep
You can stop it, switch it off. Right for right. Lights on. Lights brighter. Iska.
So it's good. Yeah. So I think if you're okay, you can.
Yeah. Okay. I'm fine. Like you can see here.
Fine, sir. Yeah.
This is the head end. This is the leg end, and the 12th rib is here, and this is the iliac crest. Now you see the distance between the iliac crest and 12th rib is like my one finger length. It's around 7.5 centimeter long only. So you get a limited space here to work. So if you put your port downward, excess port downward, you always will be having a iliac crest in the problem while you are trying to put your telescope like this. So if you cannot put your telescope parallel to it because your iliac crest is going to come in the way, right? And you cannot band it properly. So it should be at the tip of the 12th rib or slightly higher up. Like in a case where there is a very narrow space, occasional cases where I can put it above the tip of the 12th rib only. What is important is this is an open access, and we all know that neurovascular bundle travels like this, right? So the neurovascular bundle should not get injury, especially if artery gets injury. It is difficult to control sometimes because the opening is very small. So we have to extend the incision in that case. If you extend the incision and if it is a muscle deep, then sometimes the gas leak is likely to happen intraoperatively, which makes the life little difficult also. So these are the few points. Second is like I always mark the erector spinae muscle lateral border. Like here it is like in this case, if you see the midline is here, my patient is slightly slanting to my side itself, the operating surgeon side, and this is the distance. The patient is not only obese, but there is a muscular patient also. So that's quite a thick erector spinae muscle. I just put a mark over here so everything should be anterior to the erector spinae muscle, right? Roughly speaking, in an obese patient, where the things are not easy to palpate, all the things are not easy to palpate. So renal angle is always palpable, like at the lateral border of erector spinae muscle and the inferior border of the rib. That is by and large is always palpable even in this condition. If it is still not palpable, you reduce your breakdown of the table. So then it is not too much stretch, and then you can palpate, and then after you mark it, and then again you stretch the flank region like that, the kidney position. So once you make a renal angle very clear, roughly speaking, 3 finger breadth anterior to that, you put another port, and another 3 fingers breadth anterior to that, you put a port. So it is very important, like if you put a very far places, then the surgeon's shoulders are at stretch, especially my size person will not be accommodating like one port is here and other port is here. That means you have to work like in a very difficult situation. So they are reasonably closely placed ports in a retroperitoneoscopic surgery. Always we access by the open access, not by the any like blind ending trocar or anything. We cannot put it here the way we put it otherwise in a transperitoneal. So these are the few differences compared to the transperitoneal approach. Finally, the incision, by and large, I mark the incision. You can see my hand glove size is 6.5 centimeter. So, and my finger length is 7.5 centimeters. So I don't have to use my scale every time. You can always measure what is the size length of your finger. So roughly speaking, if you can see, like the size of the incision is like the length of my finger. So around 6.5 to 7.5, anything between 6.5 to 7.5 centimeter size incision is good enough, where I can introduce my hand like this is my this hand. As soon as I will put incision, will put a jelly on my hand and will introduce it right up to that. So everything is marked very clearly, and then after we can proceed for the surgery. If any question is there, I am happy. Otherwise, I ended. Just we can discuss now the pathology of this case, which is also very important before we start putting the incision. Yeah, just can you rotate the camera here and show that? Here. I want to show it here. So I know that show it here. Okay.
So this patient had a history of stone disease on the other side.
Yes.
At least the stones are out and the kidney is fine.
Can I have the artery forceps or something which is not to be used later on? Yes. Right. So yeah, the patient had a urolithiasis on the opposite side. URS was done in the left side, but I am interested more showing in the right side. If you see the right side liver is little large, probably it may be a fatty liver. We have not done any ounce per unit measurement. What is the brightness of this thing? But if you can see, this is the 12th rib or so, and then liver it has enlarged significantly. So this is another thing, like transperitoneal. There are some large liver, and then you have to lift up the liver. Here, that problem doesn't come at all in a retroperitoneoscopic surgery. Second, if you see the upper pole onward, like these are the sections where there is a calcification you can see, and there is hardly any parenchyma, but parenchymal calcification, no caliceal system is seen, complete distortion of the anatomy inside, most probably, and you can see curvilinear, and which is not only in parenchyma, but also it is extending probably into the calices. These calcifications are extending everywhere, right? So, and if you see the final reconstructive images, can you show it here? Focus it here. Yes. So then this, you can see the calcifications in the PC system, or it is in the ream here also. There is no architecture, practically speaking, inside the kidney, and there is a small size kidney. The ureter is seen. Probably there are multiple strictures in the ureter. And the main complaint of this patient is a dysuria and increased frequency of urine. She was detected to have a diabetes mellitus type 2. I think whether it is and recurrent pyuria. So probably we are dealing with the genitourinary tuberculosis until otherwise in this particular case. And let us see what histopatho comes at the end. But we all know the tuberculous kidneys, they are often having some inflammation. You can see the surrounding fat and which is quite significant. But I think we will go slowly and taking out the kidney in a planned way. There is no difference in planning of the tuberculous kidney versus other kidney. Only thing we are likely to have a more adhesions, and especially the lymph nodes are present at and around the hilum. Then it will take time, and maybe some oozy dissection is expected. That's what just I wanted to say. I'll just drop down this.
Has the tuberculosis workup been done? Is it negative? Or?
I'm sorry, I don't know much about it, but I don't know right now, but I think this is just thinking about it, or it may be
a lot of time, some neural calcification also sometimes can be taken as a ureteric stone. So I don't know other side also.
Yeah, agreeing. But the opposite kidney appears normal at the same time.
Now that you are going to take out the kidney anyway, the histology will know.
Correct. And second thing, there is no history of urolithiasis on the right side, and there is the calcification. Why there is a complete loss of parenchyma is unexplained. Otherwise, like if it is a caliceal stone or so, then there should be a focal hydronephrosis. And
those curvilinear calcification are usually significant of about chronic inflammation, rather than anything else. So
right, it
whether
may be
it's tubercular or not, that we don't know. But
this is one of the suspicious of about it, when there is a calcification seen with such a. It may be a chronic pyelonephritic kidney also. Right, we agree with that thing. And shall we start with the surgery now?
Sure, sir.
Right. Can you have a top light ready? Yeah. Right. So here is no, like not cautery, no knife.
I think too many screens we are seeing. So if we can see the surface view for what Dr. Pranjal is doing and what Dr. Jamal is doing, that so we can just have two split views.
We will not use that camera. We'll use this camera only to see the surface view. So the thing is, reduce this light. You can reduce it. But don't stop it. Reduce
it's okay. I think we can go back to Dr. Jamal as Dr. Pranjal gets ready for his incision.
Yeah, I'm ready for my incision. If you want, or maybe you can switch over there. I think Dr. Jamal has already explained about the incision, so I am not going to repeat those things. We can straightforward go in, and then after we can discuss out the next step.
Maybe we could have just an equal
Can we
split.
shift the audio to Dr. Jamal's later?
An equal split of both the screens rather than having an outside view.
Dr. Jamal, you're with us.
We were last speaking.
Yeah, we can hear you now. Yeah.
What I've
Dr.
done is
Jamal.
I've opened gerotus fascia. Now, if you're doing an nephrectomy, you see this is a gerotus fascia, and if to access the kidney and its surrounding structure, you have to open it formally, right? So, just a minute. The reason we're fogging, just change the gas from here.
Probably some fogging there.
Yeah, no, actually, the gas was going into the camera port. We just changed it. We should have done that before. Just with hot water, please.
Other thing I realized, this paranephric fat in retroperitoneoscopy sometimes can keep coming and hitting your and becomes irritating. Is there a way to prevent that?
Absolutely. So I don't know if you noticed, at one point, the paranephric fat hanging over the upper pole was impinging on my camera. So I went inside, I just hold this, and I excised it. This is what I've excised, and it's made my life a little easier. Hold this. So if you go up if you have, like, for example, it's not happening anymore. Suppose this fat was troubling you, you can go up in a 30-up position, use your ligature and a grasper and just excise this. So early formal excision of dangling paranephric fat is a very valuable thing. And it's something that plagues beginners, but once you recognize it and learn to deal with it, your life becomes much easier and your success rate goes up.
Any specific area where you'd like to incise the gerotas, depending on whether you're doing adrenal or kidney? Or
if you're doing a kidney, you have to excise it top to bottom. Because it's an adrenal, I've not excised. I've excised about halfway down the kidney. Fix that. Right. So even the perinephric fat is fairly adherent. I've seen the upper pole.
I think we lost your view, Dr. Jamal. Can you? Yeah, that's fine.
Yeah. So come out, Mira. So I've seen the upper pole of the kidney, which is one of the things you want to see when you're doing an adenectomy. The rest of the kidney you don't have to worry about much. It's not a very large lesion, but it's I think 6 or 7 centimeters. And one of the things you do worry about is that these lesions sometimes they impinge on a sort of medial side, and they can compress the hilum of the artery and the vein of the kidney. You just want to be very, very careful here that in endeavoring to dissect the lower part of it, you don't injure the renal hilum. As I said, usually, myelolipomas, you don't expect them to be very adherent. So you can, I think what we're seeing here is the outline of the lesion. This is the upper pole of the kidney. This, I think, is the myelolipoma. It's encased in adherent perinephric fat. So if this plane had been fairly easy, I would not have dissected here, because this serves to hold the lesion up, and you just develop this plane. But because maybe past pyelonephritis, this perinephric fat itself is adherent. I'm just going to mobilize it all around a little bit.
Dr. Jamal, one more port can be placed sometimes if needed.
See, I've rarely done that in my life, because already things are fairly crowded. If you see a surface view, which I'll try to show you in a bit with the laparoscope, there really is no place for another assistant with another instrument. The clashing is just going to get worse and worse.
Are you able to appreciate the bulge of the myelolipoma, or?
Yeah, I think so. This is the lesion. This is the lesion. You can see it moving now. And this is where I really wanted to go in, but it's just a bit stuck here. So I'm just going to go really slowly. As I said, even if you look at the CT, the kidney's been pushed down a bit, cumber. Okay, so now this is cut gerotus fascia, it's not peritoneum, and because this hole is slightly small, I'm going to incise it a bit with ligature, just open up the window that I have. I'm not struggling for space. I'm just going to go slowly and bluntly. Now, what's happening here is this lady's perinephric fat is continuously falling. And this is a tip I learned from Bipin. I could potentially clip this up, take it, or I could excise it. But if I do too much excision here, then I risk reaching the peritoneum. I don't want to do that. So, so for hanging perinephric fat, there are a few tips are there. You can excise it, you can clip it up, or you can just persevere slowly and steadily. One more thing I'd like to point out here, since we're talking about this, is that the role of the left hand.
Yeah.
Now, the left hand by and large retracts, the right hand operates. How much lifting of fat you can achieve with your left hand really determines. So you should be able to lift up multiple bits of the fat with your left hand, so that allows your right hand to work. And again, that is something that comes with time. Come close. For some reason, myelolipoma is fairly adherent.
So you still haven't seen the IVC and the veins?
I have not, that's right. See it once I go into here. But again, see, this discussion really comes in when you're talking about pheochromocytomas. And there's a theoretical thing that, pheo, you want to go right inside and do the vein immediately. But with current drugs available, the fact that you can control your patient pharmacologically, I don't think it is that critical. And there are several large series of retroperitoneoscopy for pheochromocytomas, which really have not, do not have worse outcomes, they've not had worse operative hypertensive episodes and things. So it is certainly a well-established modality. So you can, that whole discussion about, finding, dissecting the patient off the tumor, not the tumor of the patient, I mean, it's fine, but I don't think it matters too much.
I don't know, we all started our laparoscopy when laparoscopy actually started in the country, and so not very popular anywhere else also in the world. So we were doing a lot of open surgeries, and as far as handling of tissue is concerned, whether it was the donor nephrectomy or retinal, I realized the handling of tissue is so much more in open surgery, The
Absolutely.
assistant used to pull things and this. So when you change from open surgery to laparoscopy, you already reduce the handling of tissues. So I have seen places where when we used to do the open surgeries for POs, when the anesthetist used to start jumping and tell, oh, hey, stop. We need to control everything before you can go back again. And now when you do laparoscopy, I of course don't do that much retroperitoneal unless it is really, I have to be pushed for it. But literally the amount of handling is so little that you hardly have the anesthetist, I think the anesthetists are having a good time with laparoscopy compared to what they had when we were doing open surgery.
The same experience with us. I mean, PO is really not that big adventure anymore that it used to be. With good pharmacological control, good understanding of the pathophysiology. So I've actually reached the tumor, and it's very, very friable. I've ruptured the capsule, but because
what's that structure that you're dissecting? Huh?
Let's see what it is. It could be a small adrenal. Now, see, I'm above the upper pole of the kidney. It's highly, highly unlikely that this is going into the kidney in any way. It could
Some
be
fiber, no? It's coming from the.
We don't know. I don't really. If I'm sure that it's not a renal hilar structure, without identifying too much, I'm happy just to ablate it. I can do that. I think it's a small. I think it's a small adrenal artery. I'm not going to spend too much more time interrogating it. It's certainly going into the lesion.
The other thing that I realized that you were quite happy with the ligature without putting any clips, just to seal and move around.
Absolutely. I mean, the ligature has been, well proven and certified to control arteries up to 6 millimeters in size. That's a very large thing. An adrenal vein, 4 or 5 millimeters across is absolutely, there's no question. The only caveat is it has to be well dissected. You don't want to be, having a partial burn on it and then going on to the.
So whatever the thing is that I won't operate on adrenal without a good energy source in my hand. Now, whatever is your choice depends on you, whether it is ligature or thunderbeat or this. But any adrenal gland usually, especially the vascular ones, I think this myelolipoma can be exception because they are not usually vascular. The few especially and the cortical carcinomas, they are extremely vascular and can cause a lot of trouble, especially if they are big. So no surgery on these without a good hemostatic device on your right hand.
I would endorse that 100%. So we've sort of separated the upper pole and pushed it down. And we are seeing some normal adrenal tissue. This is the lower limb of the adrenal. I can see it here.
So when you're doing retroperitoneoscopy, you're always first going for the upper pole and dissecting between the adrenal and the upper pole and then getting to the...
Absolutely, because these are the two structures you want to separate. If I do the superior dissection first, the adrenal is just going to fall down more and more. Those upper adhesions keep the adrenal separate, right?
So a lot of time actually when we are doing transperitoneal, we not go between the kidney and that. You can use that as a thing to pull it down and dissect on the top, the liver surface first.
Again, many ways to skin a cat, but this is what really works. We've had a first glimpse of the IVC now, and it's actually we're seeing it later than we usually see it. And I can safely ablate this.
Any questions on the floor?
Okay, so we've just had a little bit of soiling of the camera, so we'll just clean it. But give me a half cross, please. Right. And just one more very little thing that I want to share that that we do is every time we take out the camera to clean it, also clean the inside of your camera port. So just like a small gauze piece, put it in the end of a Maryland, just go in and out once. So this clears small clots and fat and debris from the inside, and just reduces the likelihood of soiling your camera, which becomes.
So Jamal, there's a question from the floor from Dr. Malik that in myelolipoma, when you see the normal limb of adrenal, will you preserve it or take it out?
See, this is actually, you can very well preserve it. You can do an adrenal sparing thing. But if you look at the CT, there's a fairly large lesion. There's no normal adrenal scene. So whatever you preserve, it's really minuscule. Just in the interest of having, good hemostasis and stuff, I think in this case, I'm not going to try to preserve anything. On the other hand, this afternoon, there's a 2.5 centimeter pheochromocytoma on the left side. And I think in that case, it would certainly be worthwhile to do an adrenal sparing thing if you can get good margins. I mean, we know that, a small proportion of POs are malignant. But if you can see normal limbs and get away with taking out the tumor with a rim of normal tissue, I think adrenal sparing would be fine. Here, because really, we're not, even if we spare a small amount of normal tissue, we're not really sparing any meaningful quantity. I think that would be my take. And anyway,
adrenal sparing becomes more important in the syndromic patients with MEN2 and others.
Yeah.
Where you can prevent lifelong adrenal hormone supplementation.
Yeah, that would be the
attempt. If you spare a bit of it. Otherwise, I think a fairly big tumor.
Yeah, I would agree. Create a little space here. So, this is a good example, of how fat can trouble you in retroperitoneoscopy. I think the thing is, excise, lift it with your left hand and just be slow and persistent, and you can see it should not, prevent you from. Tumor is so friable that nothing, even if I'm gently pushing it with my thumb.
So that's IVC?
I think it's peritoneum actually.
Oh, it's peritoneum.
I suspect it is peritoneum. I see a little lower down here. So now the adrenal is fairly separated from the kidney.
Okay, there's a request to show a surface view.
Yeah.
If you have a camera, just to see how much abduction of the arms of the assistant and.
Yeah, I think that's important. So can we have the surface camera focused on me? Is that us? Okay. So just focus on my body, on my upper part of my body.
Yeah, we are. You're quite comfortable, I can see.
Yeah, so I am. See, if you look at both my arms, my elbows are by my side.
It's not very abducted. It's fine, and the shoulder is not up. So it's quite
ideally, if you look at my left arm,
I'm worried about that assistant, standing behind you.
My assistant is very comfortable.
I can't see him.
Vara, are you comfortable? Vara says he's comfortable.
He has no other
He has no choice.
See, no. Let's look at him. Don't move. See, his elbows, almost by his side. It's only a little out, and his arm is there. It's
a bit abducted. Means
a little bit, but he can move around. He can go left hand, right hand. He doesn't have to stand behind me. If he wants, he can. If he wants, he can stand like this also.
So
move up to one side. So it's fairly flexible. It's not a very big thing.
So if you see his right hand right now, the way it is resting, and the camera, it gets abducted when he holds the camera. When he's resting, his shoulder also is a bit rested, and when he's holding the camera, so there is definitely there. I don't think that part can be taken off from retroperitoneoscopy for the cameraman.
So one more thing. This lady has a very large trunk. If I did, this table is not as low as I would have wanted it to be. So if I could take this table down by 3 or 4 inches, I think some of these issues would no longer be there.
Okay.
So a small question, sir. So in retroperitoneoscopy, what happens is we are using the standard laparoscope and the standard retroperitoneoscopic instruments. Whereas to make it more comfortable, the length of the instruments and laparoscope length also should be a little bit smaller. This is what makes it difficult rather than the positioning or the use of retroperitoneoscope. So if you use the proper length of the instruments, then it is as good as a transperitoneal surgery.
That's just
Sir, one small question. Hello.
Yeah.
Sir, like I was trained and experienced in the basically intraperitoneal surgeries.
Yes.
So where we basically first look into the IVC and then go vessel-based approach.
Yeah.
So here we straight away go into the kidney and then dissect the upper pole and sweeping the upper pole. How safe is this, sir? Like
Safe, safe in what terms?
on the vessel dissection. I mean, is there any experience on like while doing that the vessel get heavens, especially veins are supposed to be very.
See, as I said, when you're doing with a very small adrenal lesion, doesn't matter. When you're doing a more sizable lesion, you should be very cognizant of the relationship of the tumor with the renal hilum.
Yes, sir.
You know, you should study the CT scan you have. If your CT is really not giving you information and your lesion is abutting the hilum, maybe repeat your CT. Don't compromise in your imaging. And then just, your dissection, don't divide anything that you don't know about. Right?
Okay, sir. And then at this point, like you never look into a renal hilum, sir, like where the renal vein is.
See, I'm above the upper pole.
Yeah.
This is the upper pole. I'm like 2 centimeters above it. There's no question of the renal. At the same time, it is possible the renal vein is originating here,
Yeah,
here,
that's
but that's why I'm going to do everything sort of slowly under vision. I am cognizant of the fact that I'm sort of close to the hilum.
Okay.
I'm not going to take large chunks of tissue and divide any structure unless I know that it's nothing significant.
But you don't look for it actually.
I am looking for it. I mean, I'm looking for its absence.
Okay, sir. I mean, do you define the renal vein before going into this?
No, not at all.
No.
Now, do you really require to define the renal vein? The anatomy is pretty clear here. He is above the upper pole and he is able to see the IVC. So,
in the general course, what we see, sir, the renal vein will come to the IVC.
Come close. Yeah, I'll just answer you.
Yes.
Basically, when you do an adrenalectomy, whether you do it right or left, in the right, what happens in a bigger adrenal is the kidney is there, the adrenal is here.
Yes.
The kidney gets pushed down. So what happens is the vasculature comes like this.
Yeah, it comes like in the.
So if you start dissecting the renal vein and then try to get to the adrenal, the renal artery will be looping around. And then the renal artery will look straight, that it will just go like this on the adrenal. So it is always worthwhile you skirt around the adrenal, but not get into the renal hilum. The second time where you actually need to look at the renal vein is on the larger left-sided tumors, because the bigger adrenal vein will look straight. So you need to define that particular vein where it is going, whether to the both ends, both on the adrenal end and on the renal vein end. So that is where only you will look at. But if you start dissecting into the hilum, then you will lose the plot, because you will end up going into other tissues and then bleed and all that. So it is always worthwhile you stay around the adrenal, and more so on the right side. Never get it, because the right adrenal vein, right renal vein is friable. If you have a bleed, you will end up with a nephrectomy along with that.
so thank you, Dr. Mallikarjun. We will go to the other theatre, OT7, audiovisual team. Dr. Pranjal, we are with you.
And I think
Dr.
just we.
Dr. Jamal, we are seeing you. We'll come back to you after some time. Don't finish the case.
So again, let us have can you see the camera?
Yes.
This is the laparoscopic view of the laparoscopic external view.
Yes.
So these are the 3 ports which we have placed as I describe it, practically speaking 3 finger breadth distance, right, between these two, between the ports. And the space created by balloon is pretty good. Like you can see the anatomy here. We have the inflation anything between 11 to 14 millimeter of mercury, gas, carbon dioxide. Now you can see the, you can see the psoas muscle here, right? This is the outside gerotas fascia inflation. So, so can you give me the scissors, please? Right. Right. So this is the psoas muscle. This is the gerotas fascia, right? You can see is it? Can you appreciate this?
Yes, we are able. Yeah. Can appreciate.
Okay, right. So this is psoas and this is the gerotas, and we go up like this, right? So you can see the kidney is not exposed at all. Everything is outside the gerotas fascia. So the balloon has created a nice work, and this is maybe the higher up if you go, we will dissect out all these things up to the diaphragm if it is required. So a potential space, it is not actual space, a potential space, and now we are going to make it an actual space. fat is there around it. So let us start. Venki, you come down. I'm a left-handed surgeon, so my suction cannula will be on the right side, and the and scissors will be on the left side.
Dr. Jamal, some surgeons again open the gyrotous fascia and put the balloon inside. Do you recommend that?
Is a question to Dr. Jamal?
No, sorry, Dr. Pranjal.
Okay. So no, I think it's not worth doing it. It's always outside the gyrotous. Once you open the gyrotous fascia, the pressure created by balloon is not limited to push the kidney. So our interest is to keep it a posterior dissection, right? Otherwise, because we are going to approach the hilum first rather than the kidney first. So to have a hilum first approach, you don't have to open the gyrotous at all, right? Now I'm cutting the gyrotous with the scissors. Okay, so just I made a small opening in the gyrotous fascia, lifting it up like this. Both the hands are working, and you can see the medial target is medial border of the psoas muscle, right? You can see the medial border of psoas muscle in a short period of time. Since it is a fascia, I have a liberty to cut with the scissors rather than very energy source, and that reduces the smoke. Now I'm creating a space. My first intention is to create a space rather than to approach to the hilum or to the dissection of the kidney. So once you have a large space, it is very easy. Second thing is everybody knows how to identify the ureter and in a open surgery, especially for residents, right? So the first thing what we need to do is making a space, and then lower down you identify the ureter. This is the ureter. So in 2 minutes, usually as soon as you put an incision, you can find out the ureter. You can see typical of it. It's and also on the right side, you may find out the gonadal vein also close to the ureter on this surface, on this side, right? So okay, here we just isolate the ureter. Some bleeding here, we will just close it, control it with the ligation.
The way this tissue looks, you still feel it is tubercular?
Well, it's too early to say anything right now. I think, yes, ligation, please. Because I cannot have a palpation of the ureter to say whether it is a rigid or not, right? But, and I have not dissected it completely. Just some bleeder here. So putting a suction should not be too powerful. Suction थोड़ा कम कर दो.
Yeah, sir, Dr. Pranjal sir will just go back to Dr. Jamal and come back to you. I think he's finishing off the case.
Yeah, sure.
OT12, audio visual.
Yeah.
Dr.
Gopi,
Jamal, we
can
are
you hear
back
me?
to you.
Right.
I think very good dissection, especially the initial port placement. There were so many changes. I think you have made retroperitoneoscopy doable. All those small things like fixing up the ports and the correct port placement, all those basic things, because I have seen retroperitoneoscopy, the evolution of it for last 15 years. So I know initially how much struggle we used to have just because of these small things. I think it is becoming more doable now.
That's what I really believe. I mean, the hurdles that beginners face are at the level at the time of port creation.
Yeah,
and because things don't go there, nothing else happens.
Yeah,
and a couple of attempts lead to frustration and then abandonment.
I think the fixing thing and all are very important. And the initial, the first port, that small dissection and taking a larger incision and a smaller incision inside also is very useful.
I think so. I think that's what I would strongly urge beginners. Don't worry about a small skin incision.
Yeah,
the skin incision can be as big as you like.
And naturally, the quality of the camera and the energy source, all these things have made a lot of difference, and it has made things more doable now.
Certainly make your life easy, and having an excellent assistant. So this is, going well because, Varaprasad is really assisting me well.
Yeah.
And if you want to retro, it's not just the surgeon who has to be oriented. You have to have at least one assistant who's your dedicated retro assistant. Okay, so
his position is also very good, I think, and he's adjusted to the standing behind the surgeon and understanding the surgery.
Yeah. So we've dissected the right renal vein. So I just want to show you now. This took a little longer than it usually does, but with this approach, we're right. The renal vein is very easily accessible to us, but it's not always so in a transperitoneal approach. We had to do a little dissection, I could see that, of the lower part of the lesion and a bit of anterior dissection. Anyway, now this right renal vein is well defined, it's dissected, and I'm just going to ablate it with ligature. I have complete confidence that this is not going to give us a problem. Just come closer, Bara. So I want to make sure that my energy source doesn't go on to the IVC. That's why I've spent little time dissecting it.
You're not going to use any of these clips and all?
No clips at all. This is absolutely safe. As I said, this will control a 6 millimeter artery.
Yeah.
So 6 millimeter vein really is all right. But what I will do is I won't seal and cut it. I'll put a double seal, then move a little further away from the IVC and repeat this once again. So at least have two lengths of this seal on the cava side. So that even if one gives way, the other one is absolutely safe. Now I will cut. That's the right renal vein gone. And then there's just a little bit of dropping down and mobilization left.
So you are done with all the veins and the vessels, I suppose, now mostly.
Yeah, I mean the arteries are not defined. I clipped a couple of small structures going into the adrenal, the lower pole early on. There may be another artery. Arteries come from the outer higher up. They come from the phrenic arteries. We might find a couple of twigs here, but by and large, we don't identify them. We don't look for them. They just get ablated in the process of mobilization.
Sir, one question for Jamal, sir.
Yeah.
Sir, in case while dissecting the anterior side of the kidney, there is a breach of the peritoneum.
Yeah.
How can we still can we further continue in the retroperitoneal approach?
Yeah, that's a good question.
That's one thing, sir. One more thing. And one more fear that I always have is in case we need to open, our port incisions are way below.
Yeah.
Should we join the ports or should we go for the rib cutting incision?
Yeah, both are very good and practical questions because they really apply to day-to-day problems. So let's talk about peritoneal
the first question. First, the peritoneal breach.
I've got some video clips to illustrate this when I talk about troubleshooting after lunch. But it's possible. The first thing is if the breach is small, put a Verey's needle into the peritoneal cavity anteriorly, and this will to some extent vent the gas out of there. If your space is good, if your surgery is simple, if you're nearly finished, that should take care of it. However, that may not allow your space to develop the way you want. So in that situation, you would want to try and close this rent. If it's a small rent, the way I prefer to do it is to put a line of 5 millimeter wet clips. And that you can usually close most rents that way. If you're still not able, by means of wet clips or suturing, which I don't prefer because it's difficult, to close the peritoneum, then another thing is to make the defect wide open. Just open it widely. So that equalizes the pressure on the both sides. Your working space is not that satisfactory, but it's usually possible to proceed and finish off the case that way. So it's really very, very rare that again, these are a few strands going to the adrenal. These may be small arteries here, and we don't have to try to identify them. There's a little bit of oozing coming to the adrenal. I think there may be a couple of small arteries intact. Once we complete all this tissue, that should stop. And you can see, just come close to the stump. You can see the adrenal vein stump is really very secure.
Yeah.
It's got two seals of ligature tissue on it. This is not good.
And he had his second question, which was about conversion to open and what kind of.
So again, it depends on when you convert, what kind of conversion it is, why you're doing it, and what you have left to do. By and large, if you join the three ports, you're going to end up with a subcostal incision.
Yeah.
And whether that subcostal incision is adequate for what is remaining for you, you have to decide. by and large, it does not give good access to the upper and mid pole of the kidney. So I think that when you're converting, it's actually better to do either a 12th or 11th rib incision. And this is particularly true in case of a major vascular catastrophe. So if you are, and I understand it's kind of paradoxical, if you have a major hilar bleed and you want to open in a hurry, you'll be very tempted to join the dots, but this is going to be very suboptimum access to the hilum. So if at all you have the time, you should be able, if you can just buy like a few minutes, do a quick slash incision around 11th rib, and that will give you access to the hilum. One situation where you sometimes can use a hand is if the bleeding occurs at the terminal stage of a donor nephrectomy, where you already have your retrieval incision. You can quickly put a hand in, clamp the things, and then you may be able to finish things laparoscopically, or that will at least buy you time to do a good formal 11th rib incision. If it's just a question of, of a lower pole that's stuck up and, some peritoneum opening, then you could possibly get away with joining the 3 dots and going subcostal. But again, that's a decision the surgeon will have to make at the time, knowing the anatomy of the patient, anatomy of the kidney, and what remains to be done.
So I think Dr. Jamal, you are finished with your case.
Yeah.
You can make
Jamal,
some
sir,
closing comment.
Maybe one question.
Yeah, Dr. Chandramohan.
Yeah, hi, Dr. Chandramohan.
Sir, very well done. I have watched from beginning. Initially, you had little more fat and then you dissected very well. Energy sources, any specific energy source like ligature only use, or we can do with monopolar and harmonic also?
I think monopolar harmonic will be fine because there are really no major vascular structures. The only thing I would not like to fire harmonic on the renal vein in the adrenal vein. In that case, I would like to clip it.
Okay.
But there's really nothing very significant all around. There are a few small arteries. There's just some connective tissue. So absolutely
very well demonstrated.
Right.
Yeah, fantastic job, Dr. Jamal.
Yeah. Thank you. That's very kind.
I think your teacher, Dr. God, will be really proud of you the way you are handling retroperitoneoscopy.
Dr. God is my teacher. Dr. Pranjal has also been my teacher, and a lot I learned when I came to IKT. So it's a pleasure to be doing it in the presence of such people.
Yeah. Any closing comments you want to make?
I think that's about it. Now, often I think I will maybe morcellate this. What does the audience think? I mean, when it's a myelolipoma, this fat, it's benign. So rather than making an incision this big, I'm going to trap it in a plastic bag, enlarge the camera port a little more, and just morcellate and take it out. So we can make the incision even smaller.
On the camera port, you're planning to take it out?
Probably, yeah.
Okay.
The only thing is for that, I'll need a 5 mm. Anyway, we'll manage something. So I would really believe very strongly in morcellation. We use this modified, sterile polythene bag with a ureteric catheter around the margins, which has been described in literature by the Nadiad group. And it's just a very effective, cost-effective and useful way to trap a specimen. And if it's a benign specimen, the usual practice is to enlarge the port, one of the 10 mm ports to about 3 centimeters. And you can just use a cocker and heavy scissors to extract it. So you really save yourself a larger incision. So just one more thing I'm going to do before we do the retrieval is to do a check scopy at low pneumo. You have a pneumo 5, please. So I've done this case at 15 pneumo. You can go a little lower to 10 or 12 depending on how friendly the anatomy is. That's recommended in donor nephrectomy. But especially when you're doing right side surgery on the IVC, even a small gap in the IVC could be tamponaded by 15 millimeters and bleed torrentially later. So we are how many millimeters now?
Yeah.
So we're at 5 now and things look pretty dry. So, there's a tiny amount of capillary. I won't even keep a drain for this.
Yeah, we are going to the other OT, Dr. Jamal. Thank you very much.
Thank you.
Everybody is appreciating your surgery.
Thank you. That's
you
very
must,
kind.
yeah.
Okay,
So, Dr. Pranjal, we are with you. Please shift to OT7 audio visual.
Thank you, chairpersons, Dr. Santosh Kumar sir, Dr. Ravi Kumar sir, and Gopi Chand sir. Now, I would like to invite next set of chairpersons, Dr. Prashant Nayak, Dr. V. Chandramohan, and Dr. Arvind Panda. May I invite you onto the stage, please. Yes. Chairpersons, over to you.
Thank you.
Pranjal sir,
Hello.
Dr. Chandramohan, Dr.
Hi.
Prashant are here, sir. Dr. Arvind Panda.
Doctor.
Hello, sir.
Hello, sir.
Hello, sir.
So
Good
we
morning.
have seen you dissecting, we identified ureter, you dissected
Right.
when you are on the psoas, and suddenly you went anteriorly into the gyrotous fascia. From there, we were not following you.
No, I didn't go anteriorly to the gerota. Just I'll show you.
Sir.
This is the ureter which has been dissected.
Yes.
Right, and you can appreciate this is the inferior vena cava.
Yes, sir.
I have not dissected out the inferior vena cava.
Okay.
Right, go close to this, Venkat. Yeah, right. And then what I did it like panoramic, please. So here was the gyrotous fascia which I divided upward like that.
Yes, sir.
Like that, right, and went like this. So this is the division of the gyrotous fascia. Everything is behind.
Yes.
We can see the psoas muscle, right? This is the psoas, and the medial aspect of it is here. Now I'm just lifting the kidney with my one hand and dissecting out close to the psoas muscle to identify the renal pedicle.
So your left hand is at the renal angle which is dissecting and doing the job because you are left-handed.
Yes, I'm a left-handed. Suppose I'm doing the left nephrectomy, then my the other way around.
Okay.
So yeah, there is some fat, and we deliberately I didn't go close to the kidney. I kept all the perinephric fat intact. Reason is that I'm expecting the pathology like tuberculosis. Sometime if you go inside the perinephric fat, it will be difficult. It will be more oozy. So just
while dissecting the ureter, you have gone close to it and a lot of fat was there.
Yes, it is there, and it is adherent also. That fat was adherent also. So I decided. I think we are close to the artery now. You can see the vena cava slightly tenting up, right? And we'll dissect out this part so that we can find out the artery soon.
Sir, Arvind, would you ever think about going extragerotal in retroperitoneoscopy?
Extragerotal. You have to cut down the gerotas. Kidney is covered by the gerotas.
Yes, sir. Would you like we do in a radical nephrectomy, keep the gerota intact completely?
Well,
would you ever think of doing that? In what conditions do you think?
Well, until and unless there is an involvement of the gerotas fascia, we have to open the gerotas even in transperitoneal also, because the fat content which are there, usually they are kidneys covered within the gerotas fascia, but to approach the pedicle, you have to cut down the gerotas fascia.
So one more question I'd like to ask you, what is, when you are doing in this fashion, you're trying to keep it is adherent, and you're trying to keep most of the fat intact over the kidney, how would you think about, what are the tips and tricks that you would offer to take the kidney away from the peritoneum? You have done an absolutely wonderful posterior dissection.
Yeah.
Now after that you have clipped everything. The thing is to take the kidney away from the peritoneum. And sometimes peritoneum can be very, very adherent. Sometimes when you do it for a kidney or something.
So
yes.
here, show the panoramic. Yeah, you can see the kidney is not falling down by itself, right? Because it is adherent to the peritoneum. Anterior dissection has not been carried out at all. This is the cut edge of the gerotas fascia. You can appreciate. I will dissect between the gerotas fascia and the kidney later on, so that it doesn't fall down. So kidney is going towards the peritoneum and the duodenum. Like on the right side, you can see some surface of the kidney because it's a loose tissue over here. And then if I'm retracting it, sometimes this tissue is getting teased off. That's all. Otherwise, the beauty is that you don't dissect the entire kidney first. If you dissect the entire kidney first, then the kidney will keep on falling here, and then the dissection of the pedicle is going to be very difficult. Like just you dissect close to the vena cava, and then you can see this triangle, right? This is the vascular area, vascular pedicle, and the lymphatics. You dissect out that, and then after you go anteriorly. So then no chance that you can have a problem in dealing with the falling of the kidney and then some other issues.
Sir, you are retracting the kidney with left hand and doing with right hand, and then
Yeah,
and then doing with this dissection, in case you need to retract, is it possible to put another port and retract in difficult situations?
Well, difficult situation.
Because your right hand is little fixed now.
Yeah, my right hand is fixed. My right hand is having suction.
Yes,
So whenever I want to do something with my right hand, I retract it with my left hand like this, and I do the suction like this. So my both hands are working, and it is me to work rather than somebody else to work. It's already a lay space, and if you try to do a lot of other instruments, they will clash in a no time. So best is, so this is the small vein opening in a lumbar, right? This is the artery, and this, go close to this. Close.
Sir, at this point, I think we also need to realize that they're just working behind the IVC. So what are the tips when you're dissecting the anterior part of the hilum to stay away from IVC and not do IVC injury here?
Yeah, panoramic please. Okay. Yeah. So IVC is an important landmark like that. You don't go close to the IVC, but you just identified the upper edge we have identified, the lower edge we have identified here, like we can dissect and we can see the, show it here. Probably here is the gonadal vein, right, which we will dissect out soon. So once you dissect out the landmarks, there are less chances, and by and large you do the blunt dissection, remain away from the IVC, right? Right, don't go very close to it, and then you can take down the fatty tissue, fibrofatty tissue, which is usually some lymphatics and some of the fibrofatty tissue around it. That's all. I don't think so there are any specific thing how to prevent good blunt dissection with both the hands and identifying each and every structure. Like here you can see the gonadal vein probably inserting into the
IVC.
Yeah, into the IVC or maybe into the renal vein on the right side. We don't know sometime. Right, it happens. So we need to really find it out.
Because in a transperitoneal approach, generally you push the IVC away and you dissect the hilum away from the IVC. But here, by the nature itself, the hilum gets pushed close to the IVC. So yeah, you need to be a little bit careful.
Right, absolutely. Go close to this. I'll tackle this vein first because it's you can see the things is pulsatile. That means I have not overstretched. If I overstretch, the pulsation will disappear, right? And then there are chance of bleeding also, either from this side or from this side. So best is not to do that thing. I like this blunt ligature, straight tip, right? And to dissect it out very slowly. And ligature is good enough to control this vein, I believe. No need of any clips, right? And then that's the right renal vein. So you have a right renal artery here, you have a right renal vein here. It's a small kidney, and the lymphatics have been dissected out by and large. There are few flimsy things. We are ready to apply the clip.
Okay, there is no formal tea break. Probably tea and snacks are ready outside. You can have it.
Well, you're telling to me?
It is to the audience. You are enjoying your IR dissection, sir.
We'll have a cup of tea, sir, while we enjoy your dissection.
Thank you.
Thank you, sir.
Sir, when you are getting a structure like this, when you are getting a lumbar, it is much easier to deal with the lumbar through a retro approach than a trans approach. Trans approach, it becomes quite tricky.
I think it's a biased opinion what is tricky and what is not. More you do, more you like I do both retro and trans, but I tell you trans is little difficult compared to the retro. Reason is like usually you don't see so many lumbar veins on the right side, right? One which is there and which is quite posteriorly located, so you don't have to go there. You remain on the ventral surface of the IVC, right? And so it's not a problem at all to dissect out the lumbar vessels at all. On the left side also, just I think there is a blood here coming.
So in a trans, you will not be able to approach that kidney without dividing the lower lumbar.
First is clean the. Let us clean it. I think we will discuss that for the left kidney. Maybe the next case, Dr. Bipin is going to show the left side nephrectomy. It will be easier to discuss about the lumbar vessels there, because right side you don't get so many lumbar veins. Occasionally only you get it, if at all it is there. So probably I will leave that part right now to Dr. Bipin's case. But
to be like all the vessels, named vessels are to be identified first. Without that, give it to me. I think it's not, just a minute. Give me the hot water, please. If you identify vessels, then after and deal with it, then make the main pedicle free of any other tributaries or any other branch arteries, then probably that is the principle of any surgery, like what we do it open, what we do in laparoscopy. You have to make identification of all the named tributaries and then after only we can go with the main pedicle. So if we stick to that thing, will not be having any issue whether it is a open or it is a laparoscopic surgery, whether it is a trans or it is a retroperitoneoscopic surgery, right? Just leave it, sister. Okay, we are clashing there inside. Yeah.
So any questions from the audience, please? Sir, Mallikarjun sir.
Pranjal.
Yes, sir.
Mallikarjun here, very great dissection, wonderful as usual.
Hello, sir.
No, I just want to have it. See, many times when you do a transperitoneal nephrectomy, we see some lower polar artery which springs from the aorta and come towards the pedicle of the right side, anterior to the vein.
Yes.
Anterior to the vein.
Yes.
Which quite commonly happens. It's not
Yes,
a very
of course.
unusual thing. If you
Yeah.
have done donor nephrectomy, it's a very common thing.
Yes.
See, the thing which will not be seen in retroperitoneoscopy. If I see, suppose it is a normal kidney, not a very small kidney, you have
Yes.
taken out a small artery, which
Yes.
doesn't really signify whether it's a truly the complete renal artery or not.
Yes.
So there is the possibility that you might be having an anterior artery which is there still, and now we are dissecting onto the vein. How do you look into these matters?
Yeah, I think I think you have already answered that. Whenever there is an anteriorly located artery on the right side, right, it is usually at the lower pole. It is quite far from this place, and it is always seen in this area. So whenever you lift up the lower pole like this, you will be able to see number one, right, in this area, and that is the reason why I clear the ureter and the gonadal vein complex also. Like you can see here, this is the ureter. This is the thick wall pelvis. I still my diagnosis is tuberculosis in this case. And then before I clip the vein, I will dissect out all the structure first. Your point is
so you do that maneuver here also, I mean to say.
Yes, 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 absolutely,
That's
absolutely, sir.
Rather, we presume that there is an artery here. We
Yeah.
are not convinced about the artery, what size you have here
Yes.
is the only artery. So let us see in such fashion that we clear everything and then clip the vein.
Absolutely, absolutely.
That's exactly what I want you to do now.
Yeah, in fact, I mobilized even the upper pole. Upper pole
In
also.
fact, upper pole mobilized, the gonadal vein, so anterior structure is nicely seen. But this time, the artery which Mallikarjun sir is telling might have seen like a strand very well.
I understand. No, I don't deny that fact. You see, but that area is still is not exposed.
But
And there
I
is a lot
don't
of
think-
fat. There is every possibility that there is a vein artery which springs across anterior to the anterior to the vein also, which happens very commonly. It happens. It's not a very unusual thing. I just want him, Pranjal, he's got experience, so I just want him to clear it, expose the peritoneum there, so that we are sure that there is nothing behind or nothing left behind, and then we can clip the vein.
Sir, without making you happy, I cannot leave Hyderabad.
No. It's not a question of happy. I just want. No.
So,
I agree fully. I just want to have a resident.
I fully agree with you, and that exactly what I'm going to do here. Usually I mobilize the upper pole first, but since you asked for that thing,
Yes,
I'll
exactly.
mobilize the lower pole part first. Like everything is lifted up close to the lower pole and dissected out. You can see that this is the gonadal vein.
But it should come from aorta only, sir.
Yes, exactly.
It can't be.
I would say
Already we are so much.
That's our
other
experience.
side. Gonadal vein is seen so nicely.
Absolutely, that's exactly what I'm saying. We want this dissection to be over. There's so many people learning across. That's the reason why we say. It's only for a discussion's sake. 90% of the times we go by instinct. That's a very small kidney. This should be the artery. And occasionally it springs a surprise that you have another artery coming up. It's mostly driven by the instinct of us.
Right.
How many times we have a angiographic evidence every time?
Yes, and I tell you, sir, your point is very well taken. Reason is I have seen even in a workshop and other places that you control in a radical nephrectomy, you control the main artery, it was sizable artery.
And then you go into the
you
vein.
clamp the vein, and then after you have a
That's
bleeding from the
exactly
surface, from the hilum of this thing. So I completely agree with you, and that is my practice also. The vein, I don't like it just like that. I dissected it out, right? That is very clear. I have to separate it from the adrenal and other thing. So now my mobilization of the upper pole will start, and then lastly I'll put a clip on the vein, right? So again, show the Gerota's fascia, age of the Gerota's fascia. You can see the age of the cut Gerota's fascia here. This is the age, and then I'll now start dissecting the upper pole by bringing by dissecting between the Gerota's fascia or within the Gerota's fascia, what I can say.
That means you are not handling the renal vein now, you are directly going to the suprahilar region. In that way also, so any accessory arteries in the superior pole also will be tackled.
Yes, yes, sir. Right. So that is the intention, and that helps me in reducing the occasional time when like bleeding occurs.
Yes.
Then like especially from the vein, like once you cut down the vein and
Yes,
the kidney gets congested. Here it is a small kidney, so that question may not come.
Yeah.
But if it is a radical nephrectomy or so,
nephrectomy.
at that time so much of bleeding can occur from that, then it is of no use. And I mean, it's all mass, and then why to salvage? It is better to have a precaution first. I think Mallikarjun sir's point is very well taken, sir, and thanks for guiding me.
No, it's not. I just want, because it's most of the time what happens in a transperitoneal nephrectomy, because it is seen in front of you, whereas it is not seen in front of you. You should imagine in a retroperitoneoscopy. So I think that the steps become the same whether you do from retroperitoneoscopy or transperitoneal.
Yeah, I think it is everything
Sir,
is
but
under
sometimes,
visual.
Mallikarjun sir, right side, in fact, transperitoneal, identifying the artery becomes very difficult. Here it is more right. The first structure seen is artery.
Of course,
More
that's
problem in the lap in right side. Back to back, if artery is there on the vein, it really gives trouble.
The same thing happens if you have an artery crossing the vein here.
Yes, sir.
Coming it from
Lower pole, you are telling lower pole, like in what
huge necessarily lower pole. What happens is a thing which bifurcates faster, much earlier, crosses across this thing, and it is never seen.
Understood.
Sir, would you also, don't you also believe in putting an additional port? We already asked this question to Dr. Jamal, and he was very adamant that he doesn't put additional ports to take help. So what's your take on that, sir?
Right. I don't like unless I have to put a stapler on the vena cava or so, or means the pedicle, then and then, because that I will show you at the end of this procedure where I put a stapler port. I mean, it's around a 12 millimeter port for the. Otherwise, I don't like any. It's a relatively small space. As I mentioned, it's a potential space, right? It's not actual space. You are creating a space, and then too many instruments in a small area will be more cumbersome rather than helpful. So better not to.
So additional ports is just strict no.
Yes,
Sir, Arvind, one question. You are actually preferring a straight ligature. Now you're getting a curved tip ligatures also. Any particular reason why you prefer a straight tip ligature?
I think I should ask the question to you why you want curved tip ligature.
Sir, it might be a little easier on the curve of the kidney to. I mean, just
there is no
personal preference.
There is that's personal preference. I think you answered my question.
So dissection also might be easier with the curved one. That if you are dissecting also, because you dissect also with the ligature.
Well, I think again it's a personal preference. Like I don't think any difficulty in dissecting with the straight or curved. Maybe somebody is accustomed with the curved instruments. It's fine. I think I have no objection to that. But since years together, I'm using the same probe. So I think I'm fine with this.
Sir, just last question, sir, about the ligature. Ligature, the one of the weakness of ligature is it's a sealing instrument, and for cutting you have to use a mechanical blade that comes from the inside. So generally, after how many cases would you prefer to take a newer instrument, or because the blade becomes blunt, unlike harmonic, where it's both sealing and cutting?
Well, every instrument is having its own. Ideally, these are all single-use instruments, right? So, would like to use single but in a setup where I am working, it's not possible to work disposable way. We usually around having a 3 to 5 times we use the ligashore, and I think should be good enough. This is a workshop, so I use extensively ligashore like this. But in a other case, mostly my dissection is with the scissors. You can see there is no need to use this ligashore. You can see everything. This is the mother-in-law, right? We have to be careful with that duodenum. And
in radical nephrectomy also, the dissection will be like this below the Gerota's fascia.
Yeah, but I take this all perinephric fat. You see, here I left behind, go inside.
So you are just below on the surface of the kidney.
All this fat and everything will be towards the kidney.
Okay.
Right, not towards the peritoneum. Here I don't want to puncture the peritoneum.
So
right?
that means it is radical nephrectomy. We have to go close to peritoneum and put it off everything down.
Absolutely, absolutely. Like you dissect, and then by doing so, sometime you open the peritoneum, and then it is difficult surgery also. If that happens, so you have to be careful. Like you work in a proper plane.
Yes, sir.
Otherwise, and remember, for which stage you are doing is more important. Radical nephrectomy.
Yes, sir.
Suppose if it is a stage 1A, 1B, or maybe even a 2, then probably there is a less likely to be involvement of the perinephric fat, because the concept is now going for the partial nephrectomy for most of the tumor.
Yes,
so I think the theory behind it, whether you remain within the gerotas or outside the gerotas,
is disappearing.
It has disappeared, and mostly it is remaining with the stage of the tumor, right?
Large, close to peritoneum struck 7-8 centimeter like that. Little
and in those cases, let me tell you,
transperitoneal is better.
Yeah, transperitoneal is better. I agree with that thing, right? In some of the large cases, we have done like a IVC thrombus and other things present, very large tumor is present. We have done a combined retro and transperitoneal approach. Because what happens then, especially when multiple arteries are present.
Exactly, I was thinking, sir, if in a beginner, like we have not done retroperitoneal, you do half retroperitoneal, can you go to transperitoneal afterwards?
Yeah, it is difficult. However, once you dissect out retroperitoneum, even the colon mobilization sometimes is difficult because the plane is lost during transperitoneal. But yes, you can do it.
You can do it.
Yeah, it is not an impossible thing, right?
Okay.
You can
Nice,
do it.
sir.
Yeah.
Since you're discussing radical nephrectomy, have you encountered cases with extensive neovascularization, any bleeding while creating the space using a balloon? Or what kind of precautions should you take when you see preoperative in this CT lot of neovascularization and stuff?
Sir, neovascularization is within the gerotas fascia.
Okay.
Not outside the gerotas fascia, right? Until unless you get portal vein thrombosis or something like that, then you get outside gerotas fascia, all the neovascularization. But otherwise, most of the things are within the gerotas fascia. So when your initial balloon dissection is outside, you rarely get, I have not encountered a major bleeding at any point of time. What is important, how once you open this fascia, remain close to the vena cava and this thing, you do not get the things. If you dissect anything between the kidney and the fat, or between the fat and the, enter into the fat at any point of time, you may get a bleeding. But otherwise, it is very rare to get. And first thing what I do is a control of artery. Once you control the artery, go for the cup of coffee and come back, no bleeding then after.
Yes.
Very nicely demonstrated.
Right. So just we put now a clip over here.
Entry anteriorly so much into the confluence of the renal vein and the IVC region.
Right.
Almost nearer to the.
So we just put a clip on that. Sister, please take this.
Are you retracting the kidney with pressure now, at least now?
No. This is just like if I leave the, I think outside camera.
Leave it, sir.
Just a minute, I'll adjust it. No, it is not much. It is not that much. Just that's all. It is very, no pressure actually. This my finger can retract this much. Like you can see my finger here.
Yes.
So that is good enough to show, right? And I think with the perinephric fat we have dissected out. It's like a maybe you can see radical nephrectomy type of thing dissection here. Just because I did not want to enter into the plane between the tip is seen, apply.
Just a basic question, sir. Left or right for beginner to take up nephrectomy?
Well, I think the left is better in my mind.
Okay.
Reason is when you are not very much aware about the inferior vena cava, gonadal vein, and other things like major vessels dissection, then sometime you enter into those large vessels. It is difficult to control. It is easy to injure the gonadal vein. It's not while on the left side there is aorta, which is like in my early part of the learning, I have dissected aorta in one case considering it was a ureter. But then you see the pulsations, you see the other things, and then the matter is simplified that yes, that's the aorta, and you can't go. So even like very early days, you can make certain mistake, but like you cannot have the injury to those structures. And the left side there are robust structures rather than, and right side there are flimsy structure, or maybe once it is injured, it is difficult to repair also. So I think my preference, and identifying the vessels, you know the anatomy very well. Identifying the lumbar, adrenal, and the gonadal vein on the left side is not difficult at all. So things can be done easily. Right? I think the nephrectomy is over here.
What space is there to rotate the kidney also for you?
Oh, even it is possible even for ADPKD kidney to some
Great.
extent. So that's not a problem, right? Or even like up to 10 centimeter, 10 centimeter tumor also, that won't be a problem.
Almost retracting towards the lower side.
Yeah, we just will put it like some flimsy connections are there, we'll clear it up.
Sir, we see in many cases in the left nephrectomy that intestine takes longer to recover. It's probably the left colon is more lazy bowel kind of thing. So have you seen a difference between your left transperitoneal and retroperitoneoscopy in terms of intestinal recovery?
Well, sir, we don't have trial done like that, but I tell you, once you do a extraperitoneal nephrectomy without injury peritoneum, and there is no collection in the retroperitoneum post-operatively, the bowel recovery is very fast. And if there is a collection, then yes, definitely there is a sometime nausea, vomiting, and all this present. But otherwise, I found retro is clipless. Retro is far superior in right or left, either of these things. I'm not sure what is the physiology behind it, but one thing is no manipulation of the bowel at any point of time, and you can see here like it's no, not ligashire. Give the second clip, please.
Sir, I just have one question, sir. Sir, in retro, you have made a wonderful dissection and made it look so easy. Would you recommend that you have a good assistant also for retro, because showing this you also require little skills? Would you have your team also has to be tuned to doing retro frequently?
Yes, I think do more, automatically you learn more, right? If you do occasionally and afraid of the complications like fat will come, bleeding will come, I don't see. The difficulty is always there, and whenever you start any case, like a laparoscopic surgeon wants to start robotic surgery, initially there will be difficulty because you have to learn the machine. Same thing is here, you need to learn certain things also. So once you learn, then after the things are very simple. Like Dr. Jamal might have shown very nicely. This is another case. Like
very well done, sir.
It is finished.
Excellent, sir. You can hear the audience appreciations.
Yeah, thank you very much.
The only thing, sir, ureter you dissected with a little fat around. Can it be done at the end, sir?
Yeah.
See, you went into that fat.
See, I followed the principles of open operation.
Okay.
So first you identify the ureter.
Okay.
Trace it upward. Right, so that is the first principle which will usually we carry in a open surgery. Okay. And then the second thing is a large great vessels. If you identify, identification is important. Maybe you can see some transmitted pulsations are there close to that, yes. Right? And do not need to dissect it completely, but just you identify by lifting up or stretching up of the tissue, like in that case the kidney itself. You identify the vessels so that you don't injure it, right? And then after dissecting the pedicle. So this is the sequence which I follow, and with that the chances of injury to the major vasculature both on right or left side are minimized.
And you're in your routine OT where 5-10 cases are there lab, which one you will choose 100% for retroperitoneoscopic surgery? Or which cases you feel that it is easy and must be done with retroperitoneoscopy?
Yeah, all donor nephrectomies first.
Okay.
Followed by the cancer surgery, followed by the some contaminated cases like previous PCN tube is placed, and these patients are having contamination in the field of the surgery. So, or maybe having a suspected infected hydronephrosis where previous stenting is not done, etc., in a large ureteric stone or so. So these are the cases in a chronological
So
order.
you mean all donor nephrectomy is highly preferred for retroperitoneoscopic surgery?
I have not done any single transperitoneal donor nephrectomy till date.
Oh, great, sir.
Whatever anatomy it is, I have never done it. So this is all extraperitoneal, and we have not regretted for the same.
Great, sir.
So in case you need to dissect the ureter right up to the VUJ,
show it here.
Is it possible, or there are some issues, or how do you go about it?
Wait. I think we can't go up to the VUJ. You can just leave it. I think where is the clip? Can you show the clip here?
Yeah, that's the clip.
Right, this is the clip. I have not dissected out, but just leave the things for a while. You can see the pulsations here.
Yes.
Right. If you go little down, there is a crossing of the iliac vessel here.
Yes.
So this is the limit of dissection.
Okay.
Right. If you try to do more, there the peritoneum is also getting thinned out as you go down, and the chances of injury to the peritoneum are high. And second thing is there is no advantage of taking out long ureter. What we do is we clip the ureter over this point of time, and my incision, like my hand, will come through this place. I'm just now going to put an incision and then asking the camera person to show from within. So first we will show the external view, and then after we will show the internal view to you. Right?
That means ureteral lithotomy below L3, L4 you don't suggest?
Yeah, I don't suggest laparoscopically.
Retroperitoneoscopy?
Yes. No retroperitoneoscopy, correct.
Between L3, below L3, L4 it is difficult?
Yeah, it is difficult.
Above it looks doable?
Yes, absolutely. But I think there is hardly any indication nowadays with the good endourology are available.
Yeah, very rare.
And it is extremely rare indication.
Totally impacted more than 3 centimeters.
Yeah.
Above and below impacted.
By that time the kidneys function
is lost.
So mostly this
only will be doing.
Yeah, most of these cases are for the nephrectomy.
Yes, sir.
Right. So just we'll put the external. No, don't do light.
Any comment on pyelolithotomy, sir? Large stone extrarenal pyelolithotomy?
Sir, the answer is same PCNL. And
no, sir, in case extrarenal large stone,
whatever stone,
theoretical discussion.
I don't like that surgery at all. Laparoscopic or retroperitoneoscopic pyelolithotomy, no. I think we must understand that what is best for the patient rather than what is like what I can do.
Yeah.
Right, you can do anything if you wish to. Right, that is a different story. But like whether we justify it or not is a big question. And then if I put myself, I question myself, pottery please. I question myself, I can't justify the laparoscopic pyelolithotomy in current era. Right now,
Santosh sir?
Yeah, Dr. Pranjal,
yes,
to what you're doing, no? I know that you do a muscle splitting incision.
Yes, sir.
And I was also searching yesterday. There is no doubt that a fan and steel, which just cuts the fascia and splits the muscle in the midline, is much more painless and much more cosmetic, and long-term cosmetic result also is better. But that is something that you cannot do when you do a retroperitoneoscopy. You do have to make either a muscle cutting or splitting incision, and even the concealment of this incision is a little worse than the fan and steel. So what's your comment on that?
Yeah, I think you use.
Is also a little more.
Yeah, I think you use several adjectives, worst and other things, but I don't think so. Nothing is worst here. If you see the acceptance of the patient, we have already asked several patients also. It doesn't matter, especially when it is a 6.5 to 7 centimeter incision, right? And especially if it is a muscle splitting incision. There is no comparative data at this point of time. I think Dr. Anant Kumar has presented a paper where there is a financial incision versus the
Sir, Arab Journal of Urology, from very close to you, from Nadia, there is a paper exactly comparing these two incisions.
Right.
And the level 1 evidence that they have shown And
Right.
I looked at that data. Actually, the statistical analysis are quite good. Numbers also are just over 100. I think 54 in each arms.
Right.
And because this was always in my mind when we make these incisions, whether there is a evidence to show that what I presume is correct, and that evidence was there.
It is
not in the best journal. It is in the Arab journal, but the science of it is correct. Means statistics part of it is correct.
Fine. I think we need more trials to do like that, right? That is for sure. And what is the size of the incision you use? What is the energy you use? And how much, whether you cut down the muscle or you split the muscle, how much the incision length is there? All these things are very, very important. As I mentioned, you can see here what is the length of the incision, right? And like it's typically, I put like a McBurney's incision, and all the muscles are splitted and there is no opening of the peritoneum. So maybe we can do a more trial. I will not put any because you are very powerful in a statistics and I am not. So I will not go into that kind of discussion. But I didn't find it out the much difference in this thing. Right now here, if you can see, if there is a giving up sensation comes, right? Yeah, that has come. Right? It comes only with the experience. Right, nothing else, and then just it's a small incision like that, and just you just wide open the scissors blade, and then put your finger there, and
the cameraman is showing so nicely.
Yeah,
it can be an open surgery demonstration for the juniors also.
Right, you can see this is the size of the incision, and because I splitted the muscle, there is some bleeding, and there is a pre-peritoneal fat which has come out, right? That, and I don't know whether there will be so much of pain, like you can have an extraordinary amount of pain and requirement of analgesic is too much in this particular. I tell you, 95% of the donors are getting discharged through the same incision. I take out the donor kidney also. They are discharged within 48 hours of time and without any analgesic jelly, please.
Only thing, it's very big. This will not.
Yeah. So, like as I mentioned, like this is just jelly in my hand. So the entry is very smooth, and just I take it out and just take it out, sister. Right, that's all. Now, without any help, just I put my finger inside, right, all the things, and then going towards the kidney side. Now I'm going to show the internal view. Yeah.
You have lady's finger, sir.
Well, sir, you can have a little bit more incision if you wish to. I do have lady's finger, I agree.
Yes, sir.
It's a 6.5.
Very slender, slim, long.
When I was a general surgery resident, there is a book and they describe the character of the surgeon.
Yes, sir. Yes, sir.
You can see anyway. You can see from where my entry is.
Yes, sir.
Right? So when you ask me the lower ureteric stone, I think this is the best incision. Just you go into that incision and take out the stone below the level of the bifurcation of the iliac artery, iliac vessels from here.
Yes,
right?
Sir.
So that's and as far as this characteristic of surgeons concerned, chalega. Abhi clean ki kya zarurat hai? Right? This kidney is here, right? And so they should have a horse-like legs, eagle's eye, lady fingers,
lion's heart.
Lion's heart. So I think that you have described me correctly as a good surgeon. Thank you so much for the same.
Nice, sir. You did very well.
Right.
You are so experienced. We know about you.
Right. So this is what, and I think pneumo should be off.
Sir, have you not tried this when using an endocatch bag, or would you always prefer to put a finger?
We can put more complex things also, but it is simple. If it is a cancer, yes, I would like to do it.
Okay.
But it takes another 20 minutes time to put me this kidney into the bag sometime.
Okay.
And larger the tumor, more the time. More the time, more the manipulation. More the manipulation, maybe more chance of local recurrence. That is my hypothesis. I have not studied that, but I take out by extension of the incision to some extent. Now you can see the splitting is same, like just a bit of splitting is here.
It's closed already.
Right. So, so less likely it causes so much of pain.
No, retraction if you do pain, but here not much done.
Yeah, so I have not done a long retraction.
Yeah.
Right, if it is a small mini incision open operation, for a long time, when you retract it too much for a longer time, there will be muscle hematomas and that causes pain. But this should not cause a pain at all. And in fact, I don't close the muscle also, right?
But at the same time, sir, for 15 years, I am also doing lap pen and still.
Yes,
so much comfort pen and still patient will have.
Agreeing.
Because it is not possible here, there is no discussion here.
Yes, okay. Thank you, sir, so much, sir. So, I think we have finished this and just we close the wound and then after we just do the
excellent demonstration.
Thank you so much.
We are
sir.
very delighted to see the fact.
Thank you, sir.
The way we expected in the morning, you did it.
Thank you, sir.
Thank you, sir.
So, Pranjal sir.
Yes, sir.
Yeah, I'm Dr. Raghavendra, sir. Even though I have announced a tea break, none of the audience have gone out, sir. They are here to watch you. Enjoy your surgery.
Thank you so
sir.
much. Thank you. Where is Bipin, sir?
At least now we can break for tea. Probably we'll start soon this inaugural ceremony.
Yeah.
So, somebody is interested in seeing how to make a balloon. So balloon is going to be made. Do you want to have a look at it?
Yeah. Better, please show us.
So Dr. Chandrasekhar is going to make the balloon. You see how he makes it. Surface camera over there.
Yes, Chandra, we are here. Please.
So what is done is whatever right or left hand, index and middle finger, you take the fingers of the glove and put the bigger one first and the smaller one second. Put the smaller one first, there is a chance that you can just tie outer balloon and not the inner balloon.
No, you are not audible. Bipin?
Am I audible, sir?
Yeah, sure.
First, we have two glove fingers. One, this is the middle finger glove finger, and this is the index finger. The middle finger glove finger will, most of the times, it will be a little bit larger than the index finger glove. So first, we will keep the middle finger glove inside. Then, we are introducing the index finger glove. We should see that the larger glove or the longer glove should be first kept, so that we should be very accurate in tying, and we will not see that there will be any leak at all. Then, this is how, then we will secure it with the thread. Am I visible?
Yes.
Yes. See, after keeping the glove fingers, then I will be securing with the tie. Always to secure it, always safe to secure it with two ties so that there will not be any leak. At least have at least 20 to 25 throws on each tie. Now the second, and we should see that we will not tie one on another, so that if we take that, it will have a lot of, it will be very thick and difficult to introduce into the small incision. And we should see that there will be little bit space between the tip of the glove and the Nelaton catheter. If we snugly fit it, it will be very difficult to distend it sometimes and deflate it.
Noted.
once we prepare the glove, once we prepare this balloon, we should check for the proper inflation and deflation of the balloon and whether any leak is there or not. The balloon is tightly fit and there is no leak. And inflation and deflation of the balloon is very smooth.
We are not seeing the balloon properly.
Are you able to see, sir?
Yes, yes, yes. The background on which the balloon is of the same color, that is the reason we are not able to appreciate it.
Now,
Yes,
are you able
yes,
to see,
yeah,
sir?
Yeah. What is the maximum amount of fluid that you can put in?
To 800 ml we have used, sir. That is the most important, and we should use a good quality latex glove, sir.
Okay.
Up to 800 ml, easily we can introduce the fluid, sir. That's all.
Can you insufflate it air also?
Yes, yes, sir. We can.
Okay.
No. Open up. No need for us. We no need for us. No need for us. Yes. Okay. This is my pen. Table break. Hello?
Hello?
Can you hear me?
Yeah, please go ahead.
So this is the last palpable rib. I don't count for whether it is 12th or 11th because many times 12th will be very small. Not be able to feel it.
You are not very clear.
Can you hear me?
No. Can you be a bit louder? Yes.
So what I am saying is many times the 12th rib will be very short or you may not feel it actually. So for me the reference point, first reference point is always the renal angle. So this is the paraspinal muscle. This is the last rib palpable, whichever the last rib palpable, that at the junction of the last palpable rib and the paraspinal muscle, the renal angle here.
Okay.
That's a constant point always. So this becomes the first reference point. Same line, around 3-4 finger breadths interior to it and below the rib.
Okay.
So the tip of rib is here. I am going here. So this is the reference point. In reference to this, this becomes the first point.
But the only problem here is the camera need to be adjusted so that we can see exactly the surface where you are looking at. The surface view,
Sir,
bird's eye view.
इधर से लेके आइए. No, no, leave it. You are instructed. Up. बोलिए. ऑन करो. Light on करो. Can you see now?
No, no, not yet. Yeah, yeah, better now. Bipin, yes, we can see.
Right. So this is the paraspinal muscle. This is the last palpable rib. This is the renal angle.
Okay.
If you put your finger here, you cannot dip. Okay. If you put your finger here, you cannot dip. Put your finger in the renal angle, you can dip. Feel the dip.
Okay.
This is reference point 1. Anterior to it, around 3 fingers below the rib.
Fine.
That is going to be the camera port, and anterior to it another 3 fingers is going to be the 5 mm port. We have to just check that this lower one should not be very close to the iliac, anterior superior iliac spine, because if it is there, then sometimes the port hits against this and you may not be able to conduct.
In an obese patient, can you clearly define the psoas?
Psoas, definitely. Psoas has to be seen from inside, sir. The renal angle is always felt. I can always feel my renal angle. I do fall in that category which you told just earlier. Light on करो. Battery, please.
Creation of retroperitoneal space, is it easier in obese individuals or younger individuals, thin individuals?
Definitely in the thinner people it is easier. Only thing, if obese people are there, you can, the initial incision which you give, that you can make little large.
Okay. But what about perforation or rupture of the peritoneum? In that way, the obese individual is better or a thinner individual is better?
Actually, sir, you have to reach up to the lumbodorsal fascia.
Okay.
And there you have to be little careful in sizing the lumbodorsal fascia. So thin or thick doesn't matter. Even in pediatric cases we do. So,
okay.
I just think you should be beware of those very, very thin patients with those young individuals with a body mass of like 17 and 18.
Correct.
Because there's almost very little retroperitoneal fat, and they're the ones in which you're likely to have a peritoneal breach.
Correct, correct.
With an average or an obese patient, there the problem is different. It's the obscuring of landmarks by retroperitoneal fat.
Yeah, correct.
Jamal, if you don't mind, can you join us here?
Yeah.
So Bipin, as I always say, probably creation of the first port is really the most critical and most challenging step. So again, you have a lot of learners watching. So would you just enlighten them about how you go about this and
So,
create a port and do sort of prophylactic troubleshooting at this point?
A couple of things. One is that you see the movements. This is static. Then I move like this, and then I move like this. Don't allow my assistant to retract it. Otherwise, if I allow my assistant to do it, that situation I will make multiple incisions on the muscle. That is point number one. Right. Right, please.
You have to make sure that your tract is going in the right direction, because with cautery the muscles all contract.
Yes.
And you might find that the opening in your muscle is a little different from where you wanted it to be. It doesn't matter much, but then the whole direction of your tract changes a little bit. Just keep reassessing what you're doing, cut little by little, and make sure that your hole is of a moderate size and in the right direction.
Dr. Bipin, is it always that we need to cut open into it, or can we just bluntly sometimes make a dissection with your
Can you see, sir?
artiforceps?
Can you see the lumbodorsal incision?
Yeah.
The
Yes.
fat moving in.
Yes, yes.
So the thing is, ki once we put a blunt dissection, sir, what happens? You may tend to, give a large incision inside the lumbodorsal fascia, which you don't want to.
That's a very important point, because really the key to having a good port is to have a small controlled opening in the lumbodorsal fascia. So I know many urologists, they like to put a finger inside to create initial space.
So finger dissection.
But when you put your finger inside, your port is no longer going to be airtight around the 10 millimeter port. I think this is actually a good reproducible way for beginners to do it. I think that small controlled opening in the lumbodorsal fascia really is the key here.
So finger dissection has to be avoided as far as possible, because everybody's finger size is different, and if somebody has a thick finger, in that situation you may create a large opening in the lumbodorsal fascia, and that leads to the leak of the gas.
What is that with the peanut that you have been doing there?
Sir, I was making a space, so give me the peanut. So once you enter once you create an opening inside, okay, in the lumbodorsal fascia,
okay,
then see my hand. I am a left-hander.
Okay.
So and this is the left kidney.
Okay.
So I will put it inside and go up. Okay, I won't go interior, or I won't go down. Got my point? My finger direction of the peanut will be towards the shoulder, this way. So, and it will be touching the paraspinal muscles behind. Okay. So if we go interior, there is a chance that you may develop a plane anterior to the kidney, or you can injure the peritoneum. If you go down, basically the space will be made here. Kidney is this side, so we need a space this side. So now the balloon is inserted inside. We'll inflate it with saline. I have never used air for creating the space because I feel air may not be a good thing because of that resistance produced by different tissues inside. Saline will usually give uniform distension.
How much saline one has to put into the balloon? How do you decide about it?
So my count is 12 or 14. 50 ml to me syringe, 12 or 14 in adults.
Okay.
In pediatric cases, I think morning Dr. Chansekar already told around 10 to 12 ml per kg body weight.
No, is it depend on the body size, something like that, or I mean?
So, not really on the body size. If I am doing a partial, I will put 100 ml extra. I need some more space.
I think 10 to 12 milligram per kg of body weight is a good rule of thumb.
Are there any conditions where you get resistance for inflation?
Mild resistance is always there, sir.
Just carry on as best you can. It's happened to me once and actually in a workshop because I made the glove myself, but probably the quality of latex was not what we're used to at our center.
So normally we use Gamex gloves, number 8 size or 7.5 size.
So about 500 ml, the balloon ruptured, and you just have to carry on. You come out, take out your homemade balloon. Look for the integrity. I mean, just make sure that all the pieces of latex are there. Otherwise, you have to look for them. Suck out the fluid as best you can. Make a new balloon. Do it all over again, and you can usually finish the case. Look for your lost pieces of latex inside. The problem is now all the tissues are very waterlogged, and your cautery doesn't work very well. But especially with your modern energy sources, don't depend. They're not monopolar, so they work even in wet tissues. So you can usually finish it. It's happened to me once. I think that's the answer I can give.
Are you emptying the balloon now?
Yes, I have connected it with the suction.
Okay.
And I always place a pre-placed suture here. Then I will put my port. This is loose, this is not tight.
Okay.
Once I put it, then I will tighten it.
Which telescope are you going to use? 0 degree or 30 degree?
30 degrees.
Okay.
This is for Rizvi. Is there any necessity of combining both the retroperitoneal first for the ligation of the vessels and some large tumor?
Yes, there have been cases where people have done like that. So if the large tumor, very large tumor anterior surface, posteriorly you go and clip the vessel and then you can proceed with the transapproach.
This has also been described for laparoscopy in very large ADP kidneys. I think Dr. Pranjal mentioned in the morning also.
Yes, please.
You just go from behind, clip the because the artery in the vein are very quickly found from the back. Sometimes quite difficult from the front. You go behind, devascularize the thing, and then because mobilization may be tedious from behind, you convert to transperitoneal and mobilize the kidney and bag it and most of it.
निकाल देंगे. So then once go inside, what I will do, I will go inside, rotate my camera up 30 degree up. Can you see the on the surface view?
Yeah, we are seeing. No, but not the surface. Yeah. Yes.
Surface view.
Yes, yes, yes.
I have rotated it 30 up. After making that, I will withdraw the scope. This is the edge of the area. I'll just go inside. That's where I'll fix the port.
Okay.
I can support it with my tummy.
Yeah, I would encourage all the trainees in the audience to not feel shy, come in front, ask questions. No question is stupid. Anything you don't understand, the people here will be happy to clarify. Just come forward. There are 2 mics in the auditorium. Just any doubt that you have, come forward and ask. Make the session interactive.
So, can you see here, sir?
Yes, Dr. Bipin.
So, this is the muscle bulge. You can see the fleshy fibers of the muscle. That's the peritoneum there.
Okay.
So, first port always is the anterior port, not the renal angle port. Okay. I will just check 2 fingers here and then I will place it.
Distance between the ports, the body habitus decides it, or?
No, it should be 3 or 4 fingers. If you keep it 5 fingers, your shoulder will be abducted.
Okay.
So it's more or less
Standard all the time.
yes.
What size port is this?
This is 5 mm, sir.
Okay.
So this fixation of port is very important. That is something which is which can disturb you during surgery, because if they are not fixed properly, and you will be concentrating on the steps of surgery, and the port will move inside. Suddenly, you will find that you are struggling. This fixity of port is very important. What? Fogging हो रहा है? Section, please.
I just also like to emphasize for beginners, when you're starting doing retroperitoneoscopy, it's not just the surgeon who's on a learning curve, it's also the assistant, especially the camera assistant. So that person really needs to understand the surgery, become as orientated, takes time. Whether it's a colleague who's holding the camera, whether it's an OT assistant, whether it's a nurse, they have to understand what they're doing, and the faster your assistant picks it up, the shorter your learning curve will be. So learning it is not just like in transperitoneal, it's just primarily anyone can assist. There's also a learning curve for assistants.
I'm fortunate with me, Dr. Chandrasekhar is there, who is assisting me.
Yeah, no, I can see that his movements are excellent and he's anticipating your movements. So it's good. It's good that you have good assistants. The morning also we had excellent assistants, Dr. Vara and Dr. Venkat, who are both our alumni from IKD.
Another thing is that if you are new, you can press the tip of this artery and see where it is coming. That gives an idea, where you are going to enter. this direction is towards the shoulder.
Are there any instances of trocar-induced trauma to the vessels or the parenchyma?
Not really, sir.
Okay.
It can happen.
All right, Bipin, thank you for demonstrating port placement. Dr. Pranjal is ready, so we'll shift to that theatre for some time, but we'll keep watching you.
Sure.
Can we shift to the other theatre, please? Does it have mic also?
Good afternoon. This is a case 4, case of a left adrenal mass. A 40-year-old female with a chief complaint of headache towards left hemicranial and occiput region and sweating since 2 years and history of palpitations, tiredness and occasional dizziness since 3 months. Patient was diagnosed as hypertensive and hypothyroid outside and she was treated with a medication for 8 months, but no improvement was seen. There is no significant family history and the personal history. Outside evaluation was done. CT scan abdomen shows a hypodense mass of around 2.2 centimeter in the left adrenal gland. On general examination, patient is well built and nourished with BMI of 23.9 and good performance status. Her vitals shows the pulse rate is higher towards 116, 116 per minute and BP when measured in supine and sitting position was constantly around 160/90 millimeters of mercury. Her systemic examination is unremarkable and her metabolic workup shows a raised 24-hour urinary metanephrines. CECT abdomen showed well circumscribed 2.8 into 2.4 into 2.7 centimeter oval soft tissue mass in the left adrenal gland with enhancement in the portovenous phase and with a partial washout in delayed phase, which suggestive of a left adrenal pheochromocytoma. With a clinical history and the investigation profile, it was diagnosed as a left pheochromocytoma of adrenal gland, and the optimization of the BP was done with the phenoxybenzamide 10 mg twice daily for 2 weeks. Now the patient BP is 130/70 and pulse rate came down to 86 per minute. After PAC pre-anesthetic checkup, patient was taken for the left retroperitoneoscopic adrenalectomy. Thank you, sir. Sir, this is a CT.
We'll discuss this once.
And this is the image of the left adrenal mass. Thank you, sir. Over to Raghun.
Yeah. So what I was saying was I have an experience of a duodenal injury on the right side while inserting the port. Actually, we used to make the space with our finger only and then place the trocar blindly under finger guidance actually. And this was a case
right triangle, 3 o'clock practically.
After putting pyelonephritis, there were a lot of adhesions.
Suction.
And we placed in the
Open.
port. We did not realize that there was an injury after the surgery. The injury was actually diagnosed only post-operatively, and there was some bilious change in the brain from post-operative day 1 and 2. But luckily, it was just only probably a pinhole. CT was done, we confirmed that there was some injury, but the bile subsided on its own in just a few days. So it's not that the port-side injuries are not known in retroperitoneoscopy, but yes, one has to be careful. And wherever feasible, insert the port under vision.
So I think, inflating with a balloon before obvious recurrence happening, but why do you think it's a trocar injury? Why do you think it is a trocar injury? Why do you think it didn't happen at some other point during the
Because
nephrectomy?
it was the adhesions were there. The balloon at the lower pole we were able to make the space, but at the upper pole it was not there. And then we inserted actually the port under finger guidance only. Intraoperatively, it seemed we dissected out well the no injuries.
Interesting to know. Good afternoon, Pranjal. Where would you now?
Hi, Jamal, just we're putting the ports.
Right. So again, although it's been repeated several times, again, you could just tell us how what your approach is, how what you're doing with each port, and how you're your steps and tips for beginners?
I think in the morning what we discussed same is first port at the it's open access, and roughly speaking 3 finger width anterior to the renal angle, and open access means you are going to cut down few muscles. So and this tiny hole in a lumbodorsal fascia that gives you the leak-proof placement. Second thing is like just I want to tell how I fix the port. So you pass the stitch and tie it first stitch, but not around the port. I think just wait for a minute or so.
Right, we're always.
Yeah, just a minute because she's fixing the camera.
Right.
Lights on. CO2 on. Yes. White balance. No, not here. Here. Done.
Quite well.
Completed. So like I can show you the whole port is in right now, right? It is and I have not tied it here. I have not fixed it. Just there is a loose knot. I can open it very easily. So it's not been fixed up because I do not know how much to come out. So it has to be done under vision. Now my 30-degree camera vision is upward, not a downward vision. Enter into the retroperitoneum. Now I am withdrawing my top so that the tip should be close to the posterior abdominal wall. Hot water, please. Like you can see the posterior abdominal wall now. These are the muscles which have been cut. Just go in and now fix the camera, fix the port. I think that's important. So just show it from outside here, right? You should have a downward, yes, downward vision. Now at this level, yeah, I'll fix the port. So that unnecessary too long length of the port is not inside the retroperitoneum. Otherwise, your working space is reduced significantly. That's what the limitation of a robotic approach to the retroperitoneum. As if you have seen the robotic trocars, they have a black mark at the about 2 centimeter away from the tip. So minimum 2 centimeter length should be there inside, and that restricts the movement of the robotic instrument. That's why I think it's very important to have a appropriate space available. As such, it is a potential space. So this is the first step which I would like to take care of it. Second, like there is some bleeding here, you can see, but it is probably coming from the port side where we have operated. So I mean, we have put a open access. There is no other place, it seems, or maybe a small bleeder could be there from the fat or so. Now, the second port placement under vision, we will do it step, please, step knife, 11 blade, which is around 3 centimeter anterior-inferior to the first port. The direction is 90-degree vertical. You don't go oblique placement, otherwise problem is the working space is reduced further. So port placement is very, very important. It should be 90-degree to the patient's body. Now I'm fixing it. Sorry. Okay, anyone you can take it off. So this is a 60 kg lady. As soon as the anesthetist gave the anesthesia, there was initially severe hypertension. I'm sorry, followed by they gave a lot of fluid and dexmedetomidine and other drugs were given. Patient developed hypotension. And now the volume replacement is going on. I think when pheochromocytoma surgery is going on, I would like anesthetist to comment on the management of it. If we can, can you give the mic to this mic to him? Or any other mic? I think without anesthetist, this is a surgery of anesthetist. This is not a surgery of surgeon only. So this is very, very important, and we really need to talk to each other rather than just doing our surgery at a time when there is a hypo or hypertension. And before putting incision, I ask his permission. Shall I? Because the depth of anesthesia should be very good. I think Dr. Pandya, right? Yeah. So mic is important. Yeah, mic is to Dr. Pandya.
Yeah. Good afternoon, all. This is Dr. Sunil Pandya here. My colleague Sai is here with me. So as you all know, pheochromocytoma is more of a challenge for us, of course, for the surgeon as well. But more importantly, the control of hemodynamics is of paramount importance. And if you can just focus on the screen, both the screens. Like if you see, we have got all the infusions ready. Focus on these infusions. So in the sense that we have noradrenaline, nitroglycerin, as well as phenoxybenzamin infusions ready, because these patients can have profound hypertensive crisis as well as profound hypotension also. And importantly, in this case, we also have connected the cardiac output monitor. If you can just focus on this. This is basically just to give us, because this patient can have massive fluid shifts, and cardiac output monitoring continuous basis gives us a idea about titrating inotropes, vasopressors, and the fluids. So basically, being prepared with infusions is of paramount importance, because when the patient is in crisis, time is crucial, and we can't wait for us to load the infusions and connect the syringe pump. So getting ready for the catastrophe is important, and many times when you are readily prepared for everything, most of the time things go smoothly. So that is what our experience is.
So what invasive lines do you have, sir?
We have an art line, we have a central line, and art line is transduced to this cardiac output monitor, so that we get all the parameters, the SVRI and all the.
Is this routine for all pheochromocytomas?
Not routine. Basically, the requirement of preoperative vasodilators are quite high. In this patient on phenoxybenzamin initially was 10 milligrams BD, and then it was escalated to 20 mg BD along with labetalol as well as the Metexel SR. So 3 antihypertensive agent, and to the extent that she was having postural syncope on standing up. That means she's optimally controlled preoperatively. So,
I think half of the success of doing pheochromocytoma surgery is adequate preoperative medical management.
And importantly, preoperative hydration, at least about so that patient is adequately filled, because she is alpha blocked as well as beta blocked. We need to fill her up with adequate fluid before surgery, before we induce.
To prevent hypotension after clipping the vein.
And despite that, patient did have hypotension here, but luckily everything is stabilized now.
Thank you, sir.
Yes, thank you. Thank you.
So I think it's important to discuss and keep anesthetic. I think a confidence between the anesthetist and the surgeon is must in this surgery, more than in any other surgery. I don't say that in any other surgery it's not required, but it's very important. Now just we cut down the gyrus fascia as we have demonstrated in the morning. Also same step probably you might have seen for the nephrectomy and the morning adrenalectomy also case, and try to identify the psoas muscle. There is a lot of fat than the what we believe. Sister, your head comes in the way in my vision. Yeah, just to stand on the slightly. Just and yeah, there is a kidney there, right? Oh, give him the ligature. Just I have put it.
I think one thing that if you do retros, you'll realize it over time, especially when you study a lot of CTs, are that some people are thin on the outside but fat on the inside.
Yes.
You can have some individuals with fairly low BMI, but if you look at the CT scan, they have a very thick pannus of peri and paranephric fat combined. And conversely, there are other individuals who have a high BMI, but they have almost who have very scanty paranephric fat. So when you're assessing a patient for nephrectomy, especially if you plan to do retro, and you see the CT scan, you look at you look at the kidney, look at the stone, look at everything. But this is something you should also pay attention to.
So I try to do some blunt dissection in a small artery. He was spurting. Anyway, let's go ahead. थोड़ा सा ऊपर उठाओ कैमरा और we are there is still a spot. So I want irrigation.
Right, Dr. Bipin is approaching the hilum, so can we?
Yeah, please proceed. Please proceed that thing.
We'll come back to you in a
Yeah. Meanwhile, I'll just do the hemostasis over here. There is a small bleeder which is bleeding. Okay, sure.
So, Bipin, we're with you again.
Sir.
And can you
So,
tell us what you've been doing? It's a fairly sticky field, I can see.
So what I have done is, I have found out the ureter. Okay. So here is the stone. This seems to be the ureter here.
It seems quite thickened.
And it is stuck here, so I won't dissect here right now. This is the iliac vessel, you can see.
Right.
Here. So this is the iliac vessel, so this has to be the ureter. Anterior to it. I don't want to dissect here right now because this may lead to opening of the peritoneum. So I will just follow this, the plane between this and this vessel, try to reach there. This part is also pelvis or ureter only.
So you've opened the gerota from top to bottom, from the upper pole right down to the ureter.
Yes, so it is open. I have lifted the kidney from down and reasonably from up also, a little bit here. So this helps me in lifting the kidney up and giving a wider view.
So I think that's an important point. Often I see beginners doing retroperitoneoscopic surgery and they make a fairly small window in gerota's fascia and straight away go for the hilum. But I think the best thing is to open gerota all the way from the upper pole of the kidney all the way right down to the iliac fossa as far as possible. So don't operate in a hole. Make a big wide opening. You'll be better orientated. You'll know where your landmarks are, and that will make your surgery better.
Does the smoke of the cautery trouble a lot in retroperitoneoscopy when compared to the transperitoneal?
Yeah, maybe. Yeah, that's why if you in the morning you saw Dr. Pranjal, he was using scissors. So, but I am not that brave. I still use hook.
It does a little bit, but not really to the extent that it
it is
interferes with
manageable.
surgery.
It is manageable.
Because there's a smaller volume of gas, so it fills up more quickly. But once your surgery is established and your gas flow is good, it's usually not a problem.
Second thing, what I want to emphasize, this is the covering here. Okay, this is over the aorta, the fat over the aorta. Okay. This is the area where we have to go. If we go dissecting here, we will end up getting behind the aorta.
So you're trying to lift up the upper pole a bit, I think.
Little a bit, sir.
So that your
To have
hilum is
some
a bit
more
better
space.
exposed.
But sometimes when you open up the gerota from up down all the way, all the fat, perinephric fat, it pops out and falls onto the camera.
Yeah, sometimes it can happen. The thing is you have to try avoid dissecting the fat before you dissect the hilum. You dissect the fat before dissecting the hilum, then these problems do come.
That fat is going to fall whether you open it or not. But what I really like, usually when you're watching retroperitoneoscopic like this, your focus is all on the operating hand, which is the right hand here. But actually see how much work the left hand is doing. It's out of sight, out of mind. But your left hand has to be able to, gather up all the hanging fat and include the kidney. And part of the things that will help you in success in retroperitoneoscopy is being able to do good elevation with the left hand. So you see the left hand suction is not, it's gathering up this dangling fat. It's also, so it's actually doing multiple roles. It's also lifting up the kidney and putting the hilum on stretch. So this is something, whenever you watch retroperitoneoscopy, also pay attention to what the lifting hand is doing. Okay, Bipin, we'll go to Pranjabhai's theatre for a little while.
Sure,
We'll
sir.
keep watching you. Pranjabhai, we're with you again.
Yeah, just I try to reach to the upper pole, upper part of the adrenal gland. You can see the space panoramic please. Yeah, बाहर निकालो और इस तरफ नीचे की ओर. हाँ, this is the psoas. You can see lot of fat is there in the retroperitoneum. So just I'm trying to take out this, lift up this fat towards the kidney, and keeping the psoas always in the mind where it is there, and trying to reach to the diaphragm. So like morning, I think you have shown, you have gone initially going close to this, between the kidney and the adrenal first, and I do a little differently. I go first between the diaphragm and the adrenal itself. So there are two advantages of it. One, the upper limit. Second, the movements it's quite vascular. Wherever I touch it, it just bleeds.
Is the blood pressure very high at this time?
No. It's 104/64. That's not much. But then
some patients just have very vascular.
Yeah, it's just the moment you dissect it out, something like it bleeds. So hardly there is any scope of blunt dissection here. Go in. There are small tributaries. In the morning, somebody mentioned also the POs and the adrenal tumors, malignant tumors are quite vascular. That's the truth. We have not reached to the tumor yet, but still there is from the perinephric area, right? So just it should not be like this. It should be like this only. Yeah, that's why I'm in difficulty. Yes, so it's better seen now. Yeah.
There's a question from Dr. Mallikarjun.
Yes.
He's asking, does the splenic vein ever come into your field or into the picture?
Well, not at all, right? I am very close to you can see the veins, dilated veins, and then this is the blood supply to the adrenal. Many a time, if you observed, even after ligating the main adrenal vein, the blood pressure persistently remain high as soon as you touch the tumor, and because its adrenal doesn't have one identified artery or vein, it is having multiple vessels by and large. So that is often the reason. The splenic vein is quite far, and we'll not try to demonstrate you, but we'll always tell that where is the pancreas and where is this is the peritoneal reflection, you can see, right? And that's the area where you may find out the vein. And it is intraperitoneal, it's not extraperitoneal. So we don't need to do anything with that thing. This may be the tumor, and we are very close to the tumor. I should inform to the anesthetist, right? And that's the peritoneal edge. I should not open the peritoneum.
Pranjal,
Yes. No, it's a small tumor here, I understand. But if you're doing a 5 or 8 centimeter tumor, then
Then also you will not be getting the splenics onto the anywhere nearby.
Well, you get in nearby, but you know that you are not in a peritoneum at all, and usually you don't get a problem with that type of.
Because once you get off the gerota, I don't know. I won't do much of retroperitoneal adrenal. We've done a fair bit of nephrectomies, but I won't do a retroperitoneal adrenal on a regular basis.
No, I mean,
No, it doesn't come. It doesn't come in the picture.
Short answer is no, it never comes.
Right. So that's
Take
the
the mic.
tumor. I'm just at the under surface of the tumor.
Take the mic and ask.
Sir, Dr. Panjal, sir.
Yes.
In PO, the standard procedure, what we do is first go to the adrenal vein, clip the vein.
Yes.
Do you think the transperitoneal scores over retroperitoneal, especially in pheochromocytoma, where we directly, without much mobilization of the adrenal gland, just go to the renal vein, identify the adrenal and clip it?
Let me tell you, without touching the kidney, without touching the adrenal, you identify the adrenal vein. All these things are more of a theory rather than, yes, it is possible to dissect minimum, but you have to dissect it out, right? It is not possible that without dissecting adrenal, you can approach to the adrenal veins. And second thing, I already demonstrated that was a pedicle-like structure. You can have a artery and vein both supplying the adrenal itself, right, which we have divided. Adrenal doesn't have a single venous drainage. Adrenal is having a multiple venous drainage, and that we have observed many a time that even after controlling it, main vein, there is a severe hypertension which is happening. So my approach is slightly different because I want to separate out it from the diaphragm. So the movement with the respiration is minimized. That's number one. And number two, you know the upper border of dissection, you know the posterior dissection, and then after I will enter between in a fat between the kidney and this thing. So I have not touched the adrenal practically speaking. You can see every complex is here. I just identified it.
Yeah.
Identification is not like manipulation, right? And here everything is covered with the fat. Right, so just I'm trying to drop down that area. We'll try to reach from here, and of course there is no need to identify the renal artery or any other things like that. And then after, once I drop down this area, right, I will open the fat, see the renal parenchyma, find out the upper pole of the kidney, and then enter between the adrenal end and the kidney upper pole. So this is what I'm planning. At that time, I will identify the adrenal vein and control it. So it's not, it's a peripheral approach. I know many have a doubt about it, but I found it is very suitable. The blood supply which is coming from above is controlled, and you can see this was the one of the vein which is controlled, like with the ligature. So and we are watching very carefully the monitor, the blood pressure is arterial line is there, cardiac monitor is there. So in the modern science, it's not like that you go, nice preparation is there, you go only through between the renal pole and the adrenal, and then first control the main adrenal vein only. No, I think it's whatever. It's important to control all blood vessels equally, otherwise you get a severe hypertensive crisis. Now you can see the tumor from above, right? This is the tumor, right? And I'm not manipulating the tumor, right? It is a kidney, this is the kidney, and I'm trying to separate it out.
One by one question.
Ranjit sir, while you are continuing to operate, just will change the next set of chairpersons.
Yeah.
Thank you, Dr. P.C. Reddy sir, Dr. G. Srinivas sir, and Jamal sir. So may I invite Dr. V. Surya Prakash sir, Dr. Prashant Nayak, and Dr. T. Krishna Prasad. So may I want to the stage, please.
Okay. Now, where is the tumor is here, right?
What's happening? Okay.
So we enter here, yes, the kidney close to this.
So, Pranjal sir,
Yes.
would you like to consider doing a partial adrenalectomy, sparing the adrenal sparing excision of the tumor?
Yeah, two things. We do it when there is a significant amount of or reasonable amount of normal adrenal gland is available. Second, 10%, we need to explain to the patient, then 10% of the tumor, it's a 10% tumor, pheochromocytoma. 10% of the tumor are multifocal also. So if patient develop recurrence later on, then they should not blame the surgeon like that. And we always have intention is very good to go with the partial adrenalectomy, and but sometime patient after like it's like a partial nephrectomy.
Yeah.
We can always do, it's a benign tumor. There is no need to take out the entire adrenal. I fully agree with you.
Yeah.
Right? Now you can see this is the tumor over here, and now this is the kidney upper pole.
Yes.
So after dropping it down, so that there is no movement now I can see with the respiration. Diaphragmatic movements are not seen at this point of time, right, with the tumor, because we have mobilized it. And now I am trying to enter between the medial surface of the kidney and the adrenal gland itself.
Yes.
Right. And keeping close to the kidney rather than close to the adrenal.
Okay. This is a standard energy source, sir, what you use routinely?
Yes, same thing like ligashore is my favorite one, and I don't have actually other than the cautery and ligashore in my institution. Even these two are available is very good. We are not a very rich institute in that way. We don't have like harmonic and thunderbeat and many other things also. Right. So kidney, I'm trying to drop down the upper pole towards my side, means on the psoas muscle.
Yeah.
There is some smoke, I will just aspirate it out. Yes. And be careful, there should not be upper polar artery. Sometime if it is there, yes, we have a injury to those arteries. Sometime it has happened. Like I'm not telling with this approach is absolutely safe.
Sir, like it is done in transperitoneal, which we try to take control of the adrenal vein right at the beginning.
Yeah.
So is that a consideration in retroperitoneoscopy, or you do not?
Yeah, it is like at the same time, if you seen, the principle is that tumor is not to be touched.
Yes.
Tumor is not to be manipulated. So what I did is I disconnected it from its connection. It's from the diaphragm.
Right from diaphragm.
Right. So I have not manipulated that thing. The principle is that if you manipulate it, then chances of release of hormones and then severe hypertensive crisis are going to be there.
Now, but hunting for the adrenal vein, so is that a priority?
Yes, that is always a priority.
Okay.
That is always a priority. Just show me here. Now, what is this?
What?
Just a minute. I'll define this. What is that? Because it looks pulsatile. Go in. Looks pulsatile to me.
That's definitely arterial.
Yeah. So that's we remain above that. It's coming out from here, but where does it go? I don't know. So go in, go close.
Some vascular anomaly, sir.
Right. So this is the tumor. Whether that supplies to the kidney or supplies to the adrenal itself.
I think the upper pole is fairly away from this, so it doesn't look like it's going to the kidney, sir.
Yeah, it looks like it is there, but I mean it is in the. So you can see there is another vein also very close to that. So that's what my concern is like. It's not a single artery, single vein in a case of a adrenal tumor. I'll not cut it, just I'll burst it. Confirm that.
So the arterial supply is quite robust.
Yeah,
Maybe
quite robust.
Yeah, that is why you are encountering all those, I mean, all that oozing and bleeding and everything.
Yeah, it is true. Of course, the initial bleeding was from the perinephric area, but still, I'll put a clip over here. I think let me still dissect out on. Now I'm manipulating the adrenal gland itself because I want to confirm that it is going inside only. Looks it's going inside only.
Little unusual to find such a big artery going to the adrenals.
Yeah, it is. It's going inside only. So we'll just definitely clip it now. Give me the clip, please, sister. Clip. Anything else? You want to put a comment? I always ask my camera person because he often doesn't tell anything, allow the things to happen, and then the man bolta tha na ki aisa hi hoga. So
I remind me, Dr. Pranjal. KP here.
Yeah, KP. So better to tell me before I put a clip rather than after putting a clip. देखो सर मैं जानता ही था ऐसा ही कुछ होने वाला था ऐसा.
Yeah, I remind a lot of instances where we did that.
Right. Anyway, I just take a liberty of putting a single clip and divide it first.
So another thing maybe we could comment on. Suppose you were doing a difficult retroperitoneal, say radical nephrectomy, and you are not clearly able to differentiate your anatomy. It's worthwhile dissecting the whole structure out before you go and clip anything off, especially because the tumor itself or the mass, kidney mass itself can malrotate the entire vascular architecture. How much ever you see the CT up front, you might find that the vessels may be at slightly different locations. So I would probably do that. Any comments on that, Dr. Pranjal, sir?
Of course, I think we need to find out all anatomy, and still there is a distortion, especially in a large mass. Here it is not a very large mass, so we don't expect distortion. This is a normal adrenal gland. You can see, go close to it. This is definitely a normal part of the adrenal gland. Would you like to give me the ligature from here? I'll just cut down that part and will be.
Sir, could you please give us an anatomical orientation?
I'll just a minute.
That where is the aorta in this case, or where do you expect it to be there? And
well, although I rupture I see while dissection, I rupture the normal adrenal gland like that. Anyway, I'll just leave this tumor right now, so you can see. No panoramic. I think that must the artery which I have cut it down must be supplying the upper pole here, because this area looks slightly pale.
Yes.
Right, so there must be then separate upper pole artery coming like this, and that has supplied the kidney, which is gone probably. And this is the main renal artery.
Okay.
Right. So I think the tumor is here. This is the arterial, the lymphatics and arteries are here. This is a renal artery. And then by mistake we have probably divided the upper polar artery. It might be supplying to the adrenal also, but it is definitely supplying the upper pole, which looks little pale now. Right?
You don't find the stump towards the kidney. There's no branch.
Sir, that is the kidney. Yeah.
But it looks pale, so I think definitely we should not consider that it is not done. Anyway, it is a definitely I will consider it is an injury to the upper polar artery, right? And we try to find it out now here, the adrenal vein.
So we'll just go to Dr. Bipin's theatre.
Yeah. Just ligature, please, sister.
Dr. Bipin? Yeah.
We have
A lot of lymphatics, no?
Actually, I think this was the fluid leak that had, because in the urethral there was some perforation and then the leak was there.
Okay.
Probably this has spoiled all the field. So this is the gonadal here.
Okay.
I can see the lumbar here. I can see the glimpse of the renal artery.
Okay.
Here. So I'll just dissect this lumbar and take it and then reach it. This will be the renal vein there. First, I don't want to go there. I have to take the lumbar first. So,
Hi, Dr. Bipin, Dr. Prashant here. Just I wanted to ask, what is the role? Have you guys ever considered intra-op ultrasound or using ICG to delineate arteries, veins, and stuff?
not really.
Bipin, I saw you were, Dr. Bipin.
Sure.
I saw you persistently using the hook initially. Did you think you would get away with the hook only, or is that because of all the additions in the hilum you switched over to the harmonic? I thought it looked like as though you were going to demonstrate the whole surgery with hook, which would have been
No,
nice.
why I use hook is it is a precise instrument. Okay, the precise instrument. So it is very good for dissection. Okay. You see this dissection I cannot do with ligature. So once I dissect it out, okay, then I will control it with ligature. Yeah, I do use hook a lot actually. I think KPU must be using also.
Bipin, see, you are only working with one hand. Other hand is retracting, lifting the kidney.
Sir.
Can you put one more port where your assistant will lift the kidney and you can comfortably operate with both hands? That as what we do in laparoscopy.
No, that is I avoid doing that. I am okay with this.
Okay.
Because putting additional port is going to decrease the space further. One.
Okay.
Okay. And I don't want too many people around me.
Okay.
Means, because the space is lesser.
So while I would not consider that to be a very sacrosanct law in retroperitoneoscopy, there have been a couple of times where I've put in a fourth port.
No, I do
Sure.
put. I do put. If I'm doing a partial, most of the times I do put, and at the time of this.
Yes, so so this is the 3-port technique. It's like what Rishi discussed in the morning, saying that if you wish to, you can have even a 5th port in there for
with so many ports,
one assistant. So with so many ports, yes, you're working.
With so many ports around, you won't be able to work out. That's what I see.
Dr. Bipin, what are those vessels that you're trying to clip?
This is lumbar.
Okay, lumbar.
So if it is not coming comfortably from the right hand, I will take it from the 5 mm port and do the ligature, because sometimes overstretching these veins can cause bleeding. It
We'll
can be a
go
version
back
of
to Dr. Pranjal's theatre for a while, because I think he's more or less completing his surgery. So I see that you completely dissected off the adrenal and the tumor.
Yeah, there is a one more artery coming out from the diaphragmatic surface side. You can see this is the artery going. This is one more artery is coming up. I can control with the energy only. We have left behind some of the adrenal with this thing. It's not a tumor, it is a normal adrenal which was seen. So partial adrenalectomy was carried out. I'll just show that part. Leave it. Take it. Come out. Just put it here. Okay. Now this we'll see the rest of the part of the hemostasis, because
So this is not a very large tumor. So how do you propose to take it out? extraction would be just by enlarging the port, enlarging camera port?
Yes, that is also possible, but then I have to bag it first.
Yes, because
And,
it's a malignant
yeah.
tumor.
What I didn't get it is just I don't want to do the further dissection here. It's not necessary since tumor is out. What is important is this is the adrenal gland, a remnant of the adrenal gland. What you can see. The irrigation, please, sister. You can
Yeah,
see
it's quite clearly visible. One of the limbs of the adrenal still preserved there.
And if you can see the venous type of pulsation, transmitted pulsations are here. So if I dissect it here, I can on please. I can find out the adrenal vein, main vein over here, rather than the in a peripheral part of the tumor. Since we have decided to spare it, I didn't go into the dissection of that vein. But I think it's since this is artery, the vein could be here. Since go close, please, go close. And would you like to dissect it and see it? Go close. Chances of a bit of a bleeding or confusion. What leaving behind is the lot of smoke coming up. So let us see. Let us confirm before we declare it anything. Let us confirm. Go in.
But I think we are pretty sure that we removed the PO in entirety.
Yes, yes.
Yeah, so this is just to look at the remnants of the
remnant part and the where is the adrenal, this the main renal vein.
Okay.
But I didn't identify that one. Probably it is here.
Yes, so you could see.
Right, you can see this, and that could be the part, the adrenal vein also here. Right, this is the adrenal vein, which I don't think right now it is required to
necessary to dissect it,
dissect it out further and to do the needful anything like that. Anyway,
Yes.
I think it is fine. That is just I will irrigate it and check the hemostasis. And what about the blood pressure? Anesthetist, and you require extra fluid or not right now? 105/60 is the blood pressure.
That's great.
And they have given, how much fluid is given till now? Near 3 liters of fluid they have infused.
Yeah.
Right.
Sir, as usual, it was an excellent demonstration. The audience is wrapped in its attention, listening there, and we can listen to the appreciation, sir. Thank you very much. Thank you. Can we skip over to Dr. Bipin, please?
Go here.
Yeah, Dr. Bipin, we are with you.
Yes, so I could find the artery.
Yeah, we can see the large artery, and probably the renal vein is just adjacent to that. We can see just behind it.
I have to dissect further.
Yes, dissect. There are some lymphatic and other tissues around it.
Yes, sure, please. Actually, the vision is not very good here with me. It's quite dull.
We are getting a good image on the screen here.
There is the vein here.
Yes. Yeah. Is there anything in between the artery and the vein? There.
Lymphatic.
Okay, just lymphatic tissues.
Yeah. It will be there. Because of the usually this vein opens up very nicely and quickly.
Mm. But
Because
this,
of the fluid
yeah.
intravasation, this whole
Yes.
area was little stuck.
Not only fluid, even this patient had a DJ stent for some time. We have seen patients who have been on long-term stenting and all that. They also have very dense adhesion. So stenting causes a lot of issues.
You guys were watching Tendulkar batting. I thought I'll make small runs.
Now we are looking at Kohli or MS Dhoni rather, yes. Tendulkar had its class. We are wrapped in attention with MS Dhoni now.
because Pranjal is very fond of Sachin, so I just mentioned it.
Yeah, we all are. Would you consider putting it rain here in this patient with all that adhesions and everything?
I will see at the end how it looks.
It's not a routine practice, no, to put it drain, not necessary.
For donors, I never put.
Okay.
For cases where partials, I always put.
Okay. Achha, he put the hand out and took it out. I asked him. And Dr. Pipin, we have a question from Dr. Srinivas, who is just asking whether you could clip the arteries now so that the rest of the dissection probably becomes a bit easier.
I'll make little space and then clip it.
Yeah, so that is what his plan is.
In the process. Get some length here.
Can you go over to the other OT? I think Dr. Pranjal wanted to show specimen to us. Sir, we are with you, sir.
Yeah, thank you. So you can see this adrenal part of the adrenal here, yellow color.
Yes, sir.
Right, and the tumor is definitely at its under surface. You can see.
Yeah.
And this is all normal adrenal. Some part is, and then we apply the ligature over here to save the residual part of the adrenal, which is lower down.
Yeah.
So the tumor coming from this area has been removed. These are the few clips which we applied. Maybe the one is the artery here, and then one is the small vein over here, which we put it early part. So I think the entire tumor is removed. We have seen, just check it, confirm it that the tumor is not ruptured, and the whole adrenal is not has come. So I think that's the reason why the adrenal vein draining into the renal vein, that part we are not able to see, since the lower part of the adrenal gland, which was left behind, is draining into the renal vein.
Yes, sir.
Right. So that's all over, and we are just closing the wound now. The BP is fine. Everything is fine. It has been, everything is fine. So you can just show that the blood pressure and other thing. As I mentioned, it's a surgery of anesthetist rather than only surgery of surgeon. So it's a good teamwork. And let me tell you, there are several occasions where we have various crises in after the adrenal surgery. Even in a post-op care unit, there is a lot of hypotension, or all these things can happen. So I think it's very important to keep a watch. It's not just fit and forget. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you once again, sir.
Thank you.
We are back with you, Dr. Bipin. So artery you have dissected all around. We are just seeing you. There's some small ooze there behind the artery, I think. Okay.
Any questions from the audience? Yeah, that's what.
Again, Dr. Pipin, the question from the floor is, why do you need to dissect it so much? I think now it's ripe for clipping. You can just put a wet.
Yeah.
Exactly.
Sir is saying that even a metal clip would do. But anyway, Dr. Bipin is going ahead with a WEC. So that's an L, I presume, L clip. Is that L or ML? L.
L.
L, yeah.
The thing is dissecting the artery completely before applying clip.
Yeah.
Just takes 1 minute extra. It is worth.
No, yeah, we appreciate the artery is totally bare now. Totally bare.
Are there any instances where you have converted retro to transperitoneal?
No, sir. In that case, I have opened it.
Okay. So you'll put the venous clip above the adrenal veins. You spare the adrenal vein.
Sir?
You are sparing the adrenal in this because it's simple enough.
Yeah.
So your vein, clip on the vein will be above the adrenal vein.
Yeah.
Is there any other second lumbar vein?
No, sir. Doesn't look like.
Dr. Bipin, right now, what are you attempting to do? What's your goal with this?
Just trying to dissect this vein.
Okay. So this is a renal vein, right?
Yes, sir.
Looks like that.
Usually this plane opens up nicely.
Yeah, this case is.
This look inflamed kidney, lot of adhesions, dense lymphatics. It's a tough dissection, I agree.
Yeah. It's nice. We are lucky to see an unusual case. So. Defining the upper border of the vein, right?
Yeah.
Somewhere close to the.
Hope it is not boring for you guys there.
No, not at all.
No,
We are. Audience has not moved from their chairs.
Would you like to see the adrenal vein or just go around the renal vein and clip it?
Actually, where I was just doing the ligature should be the adrenal vein there.
Okay. Yeah.
Yes,
Looks
we
like
can.
that. Yes.
Yeah.
That should be the adrenal there.
That looks like a quite a big adrenal vein, no? Broad one.
Too big. No?
Looks too big.
Maybe some anomaly.
This is adrenal. So that's a space between the adrenal and the renal.
Yes.
Yeah.
And
Adrenal
Let's
usually,
go up to the kidney.
adrenal usually is not such big vein.
yeah, not that broad, not that big. True.
So do you need to dissect there below? You can stay just above the adrenal vein.
The clip there,
You want to clip below?
clip there, it go up also.
Like you can put 2 clips just above the adrenal vein and cut it. Is it possible?
I'll just see, sir.
Yeah.
Yeah, we need to dissect that. Otherwise, that's to only the gonadal that comes.
Don't need, that's gonna.
Yeah, gonadal vein that is.
Yeah.
So that looks like gonadal, no? Just
Yes.
coming and joining the confluence.
You can just pull.
Ligature.
That's the gonadal vein, no?
Yeah.
Yes.
Gonadal vein.
Maybe you intentionally chose a tough case or it happened like.
But you must have known that with all that history of extravasation and stone and everything, so this wasn't going to be easy. Yes.
Good. Yeah, that's what he's doing. That's what he's doing. He's flipping the
Even Dr. Srinivas wonders whether you could just split that hat which is above the renal vein, so that maybe you can, the one that is hanging down. Yeah, the one that is hanging down. Okay, the gonadal vein has been cut, right?
Yeah, ligature. Just want some space around the vein to be to be applied.
Yeah.
Okay.
Otherwise, partial clip application, which I don't want.
So you want to clip the renal vein below the adrenal vein, right? Or above the adrenal vein? What's the plan was?
There is a put a clip here.
Okay.
You put a clip there.
Yeah, in that case you'll have to do the adrenal also. Yeah, fine. Wait, below the adrenal, then clip the adrenal.
Dr. Bipin, around that renal vein, would not a 10 mm right angle do some very nice dissection?
You ever use that?
Happy, I know you use that. I used to use a hook. Give me a hook.
Hook is short, and it probably will not get around that vein. So I really like to use that 10 mm right angle. It goes completely around. In fact, I got a right angle which is about a centimeter long tip, so I can go edge to edge, and you see it completely. With one go, you're able to take all that issue around.
Okay.
You've done so much. You still think you can go above that adrenal?
Here.
Yeah.
Yeah.
Here.
You can. I was thinking going to the hilum. Yeah. You just need to divide that vertical. But just a suggestion. Whatever is you think is easy for you, you go ahead. But just wondering whether that's.
Yeah, you're gonna do.
I don't know if this is the second vein.
Exactly. It doesn't look like adrenal one. It's too big. Maybe the vein is bifurcating and going into the hilum. So in that case, you can just clip below that.
Yes.
Then dissect it completely. And
Yeah, I think better you clip below.
Or Bipin, you could divide that tissue that's traveling transversely above the visible vein. You have some space, clip it there, and then as you dissect the kidney, you'll find out if that cephalic vein is going in. You can clip it separately.
Dr. Jamal, what do you think? Is that the adrenal or renal vein bifurcating?
Difficult to say, but I'm saying divide the large vein above, and then once you mobilize things, you'll find out automatically.
Or is it okay if he clips below bifurcation?
Do that, but the whole thing is in a non-donor nephrectomy, you should leave as
Same.
much tissue behind around the aorta.
Yeah.
You minimize complications then.
Yeah.
Just stay as close to the renal sinus and hilum as possible.
It's almost size of the renal vein. Adrenal, what we are thinking it is.
Yeah, that doesn't look like way larger than any adrenal vein.
The direction is suggestive of an adrenal.
Adrenal. True.
Not related to this, Dr. Bipin, but strategies for hemostasis when you have a venous tear or a venous injury.
So first thing, put a gauze piece, wait for some time. Second thing, you can take sutures if possible. Third thing, convert it to open. Clip. Take a shoot, clip.
Dr. Bipin, if there is an accidental peritoneal rent during the dissection, what do you do?
So first thing is ki put a varus needle.
Okay.
Okay, that intraperitoneal varus needle, that will take care of the air which has entered into the peritoneum.
Peritoneal cavity. Okay.
And then you try to see where the rent is.
Okay.
Clip it. And then if the rent is seen, you can clip it. Multiple clips can be applied at the edges.
Okay.
And that closes the rent. I think Dr. Jamal has a lecture on that.
Okay.
So troubleshooting is there. My lecture was there.
Filling up.
Filling up.
Vein is filling up.
Yes, two clips, no? One side, one more.
Then anyway, that side also has to put.
I think maybe another artery is there also, I don't know.
Yeah.
And they used to put one more clip in the top. Just
Then the hilum is done.
Yeah, hilum is done. We were only worried that the renal filling was there. Once you clipped it, it appeared to be filled up. So, but in imaging, we didn't see any other vessels, any other arteries. So, would you like to drop the kidney now from this thing, peritoneum, or how would you go about it?
Yes.
Okay.
Vipin, have you used staplers for the hilum?
For right donors, I use.
For vein? Arterioles?
No.
Oh,
Only vein.
vein. Which stapler do you use for the vein?
Endo TA. Or if endo TA is not available, the master is sitting there, Dr. Jamal. He modified it endo GIA stapler, which we were using for a very long time at IKD when endo TA were not available. But now endo TA is available.
Okay. What is the pressure now, Nemo?
It is 16.
16.
Right.
Is that what you normally always work at?
Sorry?
Is that what you normally always work at? 16?
Usually 40 to 16.
Okay. No, whereas
Whereas please.
there's abdominal distension.
Please give whereas.
Crowding. There must be some small, very inside. Are you putting a Harris or something?
Yeah. I put a whereas.
Okay.
I cannot see any red as such. I don't want to see also.
Okay.
So you seem to have a fair amount of space around the kidney, Dr. Bipin. Have there been times in such adherent or inflamed conditions where you had to do subcapsular?
Yes. Yes.
So in this patient, would you get into the gerotas close to the kidney now? Is it?
Yeah, that's what I am trying to do.
Okay.
You can see the glimpse of the kidney.
It's not as bad as what it was looking all this time, but
yes,
I'm sure there have been times where you just couldn't progress at all through this plane.
One of those bad excipients and all that. Where so.
I did not go and dissect out the ureter down. I just saw it. It is still adherent there. Intensely, I did not dissect because if I would have tried dissecting the ureter at that time, there would have been definitely a peritoneal rent and would have been very difficult to progress. That is
Yeah, the stone.
That is what. I don't know. Here actually the hue is yellowish hue coming on the monitor.
You have a very good vision.
Actually, we are getting a great vision on the main screen, and the yellowish view we are getting in our Photogona monitor that we are having for chairperson. So there it is a little bit blandish and yellowish view. But on the main screen we are getting a great view. So there must be something.
What is your imaging system, Vipin? Which one you are using?
This is a Sony monitor actually.
No.
Of Olympus.
Starch or
Olympus.
Okay.
Yep. Missing.
Yeah, that OEM work manufacturers for medical manufacturing.
Just remove this fat, it will give some space to me to work.
How do you proceed in a grossly hydronephrotic kidney, Dr. Bipin? Then because it will be occupying a lot of space.
Yes, so if it is a very large hydronephrotic kidney, just before starting the case, you can just put a PCN.
Okay.
So that makes the life very easy because everything is deflated.
Okay.
If it is very grossly hydronephrotic, that is what I do.
Well, if you completely decompress, also sometimes very difficult. Entirely collapsed kidney mobilizing is also difficult.
Yes, so but only thing is it remains inside zerotas.
Yeah.
So that helps.
What I sometimes do is I put a trocar into the kidney.
That can also be done.
Decompress and then distend the kidney with carbon dioxide to extend what you want. This we published, like I coined the name as pneumorenum, and we published in the Urology Gold Journal.
Oh, great. Pneumorenum.
Pneumorenum.
Very nice terminology. Yes. It should be made something like Surya Prakash technique.
CO2 just make it there. Fluid and then just
The camera is still 30 down, Dr. Bipin.
Yes.
Would you like it to be 30 up?
Till I am comfortable, it is okay. Or else I will make it.
Because you're working at the edge of your vision.
There is a small upper polar branch which is bleeding.
No. I think a little, it is subcapsular.
Okay.
Any particular reason you're persisting with that, Dr. Bipin? I mean, sometimes what I feel is just taking it off along with that fat just makes your life so much more simpler.
Always remove the fat in simple nephrectomy all around the kidney.
Not really.
Okay. Because in transperitoneal we always stay extra gerotal. Like everything is radical.
It depends on the level of addition. I mean, if you think we can get away with making a plane outside the fat, a lot of times you just take it out with the fat. The specimen becomes a bit bulky, but maybe you would probably get away with avoiding this dissection at times.
I think when you're dissecting a stuck-up kidney, whether an XPN kidney or a pyelonephrotic kidney, you can't just go in with a pre-formed thing that this is going to be my plane. One of the planes is going to be friendlier than the others, and that's the plane you take. If things are really bad, you're scared of injuring the colon or the duodenum or something, then just go subcapsular and leave capsule behind. And then once you reach the hilum, you can come out of it again. So, it's really difficult to predict which is the friendly plane. It could be the radical plane outside Gerota's fascia and the paranephric fat. It could be the extra capsular plane. It could be the subcapsular plane. So you just have to take it as it comes.
I sort of agree with Dr. Jamal, because I have done a few of these cases, of course, with mentorship of Dr. Bipin. When we go for the fat, sometimes the peritoneum tears. That's the most difficult part, I feel. The most difficult part is always separating the kidney from the peritoneum, because it's totally stuck, and you take the fat, it comes along, and then you really struggle. Not the vessels, not the polar dissection. This is the most difficult part, because this is completely stuck, and peritoneum is very thin. You have to get it off the peritoneum. So I think what he's doing, just getting the kidney off, is just the correct way. Because you can't really know when the fat finishes and the peritoneum starts. The colon may be right there.
Now, but if you have the choice, Dr. Bipin, in a patient who doesn't have a lot of adhesions, would you like to separate it from the peritoneum or get into the gerota and separate the kidney?
What happens sometimes, once you try to go into the radical plane, at times the peritoneum is thin, you will open it.
Okay.
Why I'm just avoiding. I don't want any other.
Okay. So your choice is this plane between the kidney and the gerotas.
Yeah.
Okay.
I just want to ask one more question. Is there any role? I did not see any of the surgeons putting a gauze piece inside. We do in trans, we put a gauze piece, we let it settle there, we see exactly where the bleeding is, and we buzz it with bipolar or with harmonic or with like a sure.
We put it required.
I think we didn't have any bothersome bleeding the whole day, I think. So I think that about sums up, I think both in terms of expertise of people doing the surgery. So I think unwanted, sometimes misadventures in your movements tend to create that. I think a very measured movement, which the masters have shown us since morning, probably made us get away without using that lap pillow today. Bipin is definitely trying to show it to us without the lap pillow.
Just
This may be the last bit, or this is.
this area is adherent actually.
Yeah.
It's really a feast to watch, Dr. Bipin, meticulous dissection.
Thank you, sir.
Great job. Kidney looks bulky, na? Big kidney.
Yeah, kidney is not. This is what boss was telling just now.
Yes.
It's gone outside. This is what Dr. Jamal was telling.
Yeah.
Yeah, that's the peritoneum, na?
That's the
Anteriorly?
peritoneum.
Yes.
Yeah.
Once we try to go in this plane, sometimes, you know,
Yeah, remember.
peritoneum opens.
Correct.
You have your day. Better to have a bigger peritoneum opening rather than small ones. Small ones are not seen actually.
Correct.
Because that is the back bleeding of kidney.
Again, watching this, we come to realize that how important the role of the assistant is.
Yes,
Because-
yes. Retrosurgeries you cannot do without a.
Yeah, without a skilled
So
assistant.
it is like two people operating, not one people operating.
Totally agree. Totally agree. Because for him to get into that cave with you and show you
Yes,
all
so-
throughout is amazing.
It is full credit to Dr. Chandrasekhar.
Yeah.
ये इमेज आ रहा है मिसिंग बिट्स
Fail. Then we had something similar kind of issue. Are you planning to put a drain?
Sir?
No. Are you planning to put a drain in this case or no?
I think I will put it.
Yeah.
The way it is.
Yes. So have you ever had the retroperitoneum save your day, Dr. Bipin? Bleed or a urinoma which was contained and you were able to manage?
Say it again.
I said, did the choice of retroperitoneum at any point save your day or patient where the bleed recognized post-operatively contained it in the retroperitoneum or your urinoma contained in the retroperitoneum and you were able to salvage the situation? Because
Yes,
you chose
so-
retroperitoneum, if you have any examples?
Yes, so in this hospital, I think I had one experience. We did a partial nephrectomy, retropartial in a CLD patient. That patient, I think fourth or fifth day, he just fell down. He was low. So there was a collection around 700 ml or so. So I think retro in that situation helps because the hematoma is contained. It is not free to move.
So you think you will get away with a clip for the ureter, or you might have to suture it?
Just see now the situation now. See here.
Don't below, no? You need to get down. Is it possible to handle that distal ureter after retrieval from the retrieval incision? If at all you need to do that?
Maybe here I'll just dissect this out and then probably I'll give an incision, take it out.
Okay.
This area is the ureter you can see.
Yeah, we can appreciate the ureter.
That's here. Probably this was the area where.
Yeah, where ureteral injury and perforation had happened.
Yes. Good path.
So while there are no absolutes in your while doing the retroperitoneum or any surgery, would you like to divide the ureter right at the beginning?
No.
Why not?
So two reasons for that. Keeps the anatomical alignment intact. Okay. The second thing, because it's a ureter can come to your side and you can, especially in donors, you can injure it.
Sorry, we didn't quite catch that.
So if you cut the ureter at the first go, the donor nephrectomy, ureter can come, between and you can injure it. If you don't want.
No, this is strong. Somewhere in this part. Yeah, he has to go below. That is the part he didn't want to do immediately because he worried about
This
stone, Dr. Bipin there?
Yeah, it's like very hard. Shift. Take a shift, please. I appreciate you guys' patience and constructive.
We are enjoying your surgery, ma'am.
I am
enjoying.
Anything that keeps our hearts in our mouths, we enjoy that. So it was a treat to watch you overcome an unusual and a difficult scenario today. And being the gracious host that you are, you kept a difficult and unusual case for yourself.
This is iliac vessel here.
Yes.
And,
you will need to probably dissect it away from the vessels, no? Little bit, yeah.
who can
Okay. Yeah. That's not really an iliac artery. No. First, can we get on with the two other lectures?
Sure.
While we watch you.
Sure.
Right. So I think we have got two interesting lectures to look forward to.
I think
one is Dr. Rijvi, and by the time he finishes, maybe you will be able to join us for the other one.
Yeah, I think so. So I can feel the stone here.
Yeah.
Here I will put a clip.
Correct.
Yeah.
Great job, Bipin.
Vipin was excellent job. We can see the appreciation of the audience. Thank you very much for that demonstration. I think we'll call Dr. Hemant and Dr. Ali Mallikarjun Reddy and Dr. Arvind. No, they can't come over. We'll go down. Dr. Hemant, Dr. Mallikarjun.
Bipin sir, just I'm inviting the next set of chairpersons for the session. Dr. Hemant Goyal, sir. Dr. Hemant Goyal, Dr. Arvind Panda.
Bipin, is the wet clip been taken out or is it inside? The DJ stent, I mean?
DJ stent is already taken out before starting the surgery.
Okay. Once in a while it's happened that people have forgotten to take out the DJ stent. You had to do later, you clip it, cut it, come out, and then the next day an X-ray shows a cut stent.
We removed it before the.
Okay, so one more question, Bipin. Now that you have this thing here, if your wet clip isn't, I mean, there's just about taken the wet clips. Often these ureters are so thick they don't take a wet clip. Would you be happy to just cut it and leave it, or do you think would you like to overrun it with suture or something?
I'll just
because it's a non-refluxing ureter.
Apply 2 clips and take it out.
Now, what if the clips were not being applied? Suppose it was twice this thickness.
I think the retrograde of pani first can come out.
Dr. Arvind sir.
There is only one comment I'd like to make here finally. Now there's a trend for Indian manufacturers selling wet clip applicators. I think that is something which we should strongly avoid, because if the wet clip applicator malfunctions, particularly on the vein or something, it's going to be very difficult. But still I see a lot of surgeons going to buying the Indian clip applicators. I think that's very dangerous.
I just have a point to make about the Indian clip, because I was faced with a scenario where I was being asked to take up. But when you see there is no gap at the end of the Indian clip. So if there is no gap at the end of the Indian clip, that entire vessel that is trapped will get crushed. And there is a chance that it will slip off. So please avoid the Indian clip. So this is what I think. So there is no gap there, it totally crushes the vessel.
I totally agree. I think
Thank you.
So invite Dr. Zamal Rizvi sir to give his talk on troubleshooting in retroperitoneoscopy.
Over to you, sir.
Right. So we're coming to the end of the day. I'm glad we still have an audience here. So I think one thing I'd like to highlight is that a good part of troubleshooting is actually preventive. If you take steps beforehand, you're going to nip trouble in the bud. And a lot of these things we've already discussed numerous times, so we're not going to dwell on them. To prevent trouble later on. So this is got troubleshooting in advance. Your position. Okay, we need to see the slides on the screen. Okay. Anyway, you've seen nothing critical so far. So I'm just, there are only words in the slide. So, if your positioning has to be, good positioning leads to ease of surgery. Port placement has been discussed numerous times. So, I won't dwell on that. Port leakage has been discussed numerous times. And management of hanging fat, which I will talk about a little bit. So as I said, this is all preventive troubleshooting. But when trouble really strikes in retroperitoneoscopy,
the slides are up there, which they can come on the screen. Yeah.
Yeah. So the things we've been talking about, positioning we've discussed, I won't spend time. Port placement has been discussed in detail. Creation of the first port also, I'm not going to go on anymore. This has also been highlighted already that a small skin incision is going to lead to a large lumbar dorsal incision, whereas a large skin incision will lead to a small lumbar dorsal incision. And I think this is a message you've already got bored of hearing, but I think it's important and bears repetition. A gas leak from the first port. Again, one little trick is to pack the space around the port with a gauze piece, and then apply a stitch. And that usually takes care of external leak. There may still be subcutaneous emphysema. Orientation we've also discussed. You need a good attendant, and if you're losing orientation, make sure that the psoas is horizontal.
चंद्रशेखर, ठीक है ना? अच्छा, लिखा शो देना.
Now, management of extrarenal fat, I think this is important. And, it took us years and years of retroperitoneoscopy before we really understood what the problem was. We just have constant fat touching, would be frustration, there'd be, shouting, and the surgery would go on for hours and hours. So, there is limited space. Excessive fat can obscure landmarks and repeatedly soil the lens. And what I advise here is be preemptive in this, identify what the hanging fat is, go in and excise it. So I demonstrated this in a small way in the case that I did in the morning. So this is, okay, we've lost the, so again, the first part of this clip just shows you a situation where you're doing a left side nephrectomy, it's constant touching of fat, going in, going out, touching again. You realize this paranephric fat, this is fat outside your rotator sphacia next to the peritoneum. So now the camera is 30 up. And there is deliberate excision of this hanging curtain of fat. So the left hand has a grasper, you're catching the fat, and I apologize for the quality of the video. And you're just, you are deliberately excising this falling fat. And even to some extent, if the perinephric fat posteriorly is falling, you can excise that. So this is all the fat that was obscuring the hilum, and you can see that once this is all excised, this is a complete and formal excision of the posterior panus of fat. You don't have to do it routinely, but if it's interfering with your hilum, you can see that now all the fat is placed down in the iliac fossa, and your approach to the kidney is so much easier. Now, management of renal vein tributaries, this can be fairly troublesome, especially when you're doing a transperitoneal left-sided donor nephrectomy. But again, this is not really a tip. This just highlights how retroperitoneoscopy is advantageous in the management of the tributaries of the left renal vein, especially the lumbar veins. So this is a complex situation where you have a lumbar vein which is draining into the renal vein here. This is extension down. The gonadal vein is draining into that. But you have, this is sort of unparalleled exposure, both in terms of angle and both in terms of proximity that you don't have in transperitoneal. So it's really in transperitoneal, even in simple nephrectomies, there are situations where you have a cut or a partly cut lumbar vein that retracts, and taking care of it is a real nightmare because it's hiding behind the aorta. Whereas here, even if you have bleeding or you have retraction, everything's right in front of you. So I think this is one place where retroperitoneoscopic shines, especially when you're talking about donor nephrectomy. And you can dissect good lengths of, even large lumbar veins and control them by means of clips or energy sources. And similarly, this is dissection of an adrenal vein, again, which is in transperitoneal, it's very simple, but you can do it so fairly early in retroperitoneoscopy, even before you mobilize the kidney. So now management of bleeding, again, there's really nothing specific to retroperitoneoscopy, but these are just the things that you would do in any laparoscopy, so they apply here too. Any venous bleeding, the first thing is increase pneumoperitoneum up to 20. This will take care of all venous bleeding and some arterial bleeding packed with Surgicel or gauze. It wasn't necessary today, but that's always an option. Clips and sutures, a rescue stitch. You should always have ready a small segment of 4-0 Vicryl or 5-0 Proline with a knot or a clip on the end, which you can just use in an emergency to close a bleeder from the IVC or a large venous tributary or an arterial bleeder. And if you, one option that you always have is to insert your hand. So it's converted into some sort of a hand assistance. You can either do this deliberately if you're having bleeding. And one situation where this may occur is at the fag end of a donor nephrectomy. So this is often where you have a clip slippage and torrential bleeding, but often you already have your pre-placed incision there. And of course, you'd want to, for torrential bleeding at the end of a donor, you'd want to convert it immediately. But if you have that your retrieval incision, just put in a hand, put pressure on the bleeding vessel, and that might buy you a little bit of respite and allow you to control the situation.
Kamal, just for 30 seconds, the anesthesia people want to show something, if it is...
Absolutely.
You run in the OT? We've just stopped the... go ahead, please.
We're not getting the audio.
Okay, yeah. Can you, am I audible now?
Yeah, you are audible.
Yeah, basically, I was telling in the morning that we have started the initiation of ERAS-E protocol, that is enhanced recovery after surgery from the point of extubation. And this is one patient, like if this is a patient who was operated for pheochromocytoma, you can see she's pain-free. We have given her blocks, little groggy, but she's reasonably okay, motor skills are good. And you can see her walking from the theater. Basically, the aim of ERAS-E is nothing but to enhance recovery in term and minimizing post-operative pulmonary complications. She doesn't have giddiness, hemodynamics are stable. She's being monitored. We just observed the patient in the theater just to rule out any postural syncope. But if you can see her walking to the recovery room. So this is what the advantage of current anesthetic, despite major surgeries, they are reasonably good recovery. In this patient, we have used Sugammadex along with blocks. So basically, Sugammadex again is a specific reversal for occuronium, and with titrated balanced anesthesia, the recovery, even following major surgeries like Whipple's and other things, we put this patient on ERAS-C. So I thought we should just wanted to show this to you all. I can take any questions if they're from the audience, but if there are any questions from the audience, I can take it. Otherwise, you can continue your discussion, sir.
That's excellent. Thank you so much.
Thank you.
I really appreciate.
Thank you, sir.
Rajaman, please, we are back with you.
Really very impressive. Good to see. I think, all other anesthesia departments should emulate this. Maybe one day we're going to have daycare nephrectomies and adenectomies and other things. Right. So peritoneal rent, how do you identify it and what do you do about it? So you suspect a peritoneal rent when you have a lot of peritoneal bulging and reducing space in a case that was otherwise going smoothly before this. And so there are a few things you can do. I'll show them in the next videos. The first thing is to insert a Very's needle. I think Bipin had inserted a needle. I'm not sure why. I think he had some bulging. If it's a small rent, that may take care of it. If you can identify the rent, you can close it with wet clips or a V-lock suture or something, and that usually takes care of things. And if nothing's working, you have a rent, you're not able to proceed. One tip is just to open the peritoneum from top to bottom. So now what you're doing is you're doing transperitoneal from the back. And when you do this, you're usually able to proceed. And it's really a very rare situation that you have to convert just because of peritoneal rents. So this is just a short video. There's a right side donor nephrectomy in progress. And you can see that there's a bit of struggle happening. Everything's falling, the kidney's falling, the fat's falling. Things are really not progressing well. We're not able to see the hilum. And then you look up and you find, so you search around, look up, and this is the culprit. There's a large rent, and the whole peritoneum's open. So then I said the first thing is to put in a Very's needle. So just about a few centimeters in front of the port. You don't have to monitor it laparoscopically. If you can see it, it's well and good. But this is, this clip's been repeated a bit. So you put it in, even if you don't see the rent, you put it in blindly, you confirm that it's inside by a free flow of gas out of it. And then proceed to close it. And my personal experience is that 5mm wet clips are a very effective way of closing these rents. And once they're done, you're back on track. So the only thing you have to be careful about is not to extend it further by tearing the peritoneum more and more. So identify the edges, handle them delicately with a Maryland, and apply these clips precisely. And once this is done, you can see the hilum is now visible and you're able to dissect the artery in the vein well. Okay, so I don't have a clip for this, but sometimes after donor nephrectomy, especially on the left side, and this is true for transperitoneal too, you find a lot of chylous leak. And this is, you should really be at this time preempted by clipping all the lymphatics that you've cut. Otherwise, you could end up with a leak. And I think, Arvind, you were asking about whether retroperitoneoscopy has actually, ever saved a patient. So in the last many years of doing this, we've had 4 chylous leaks post-donor. In transperitoneal surgery, this can really be a life-threatening situation. And there have been reports of cachexia, sepsis, and death following chylous leaks in a donor. However, in all these cases, they came with a confined swelling of about a liter and a half, whereas transperitoneal it can go up 8 or 10 liters. And we managed them all by placement of a drain and starting them on the typical filarial diet of coconut oil and things. And some of them were started on octreotide, and we published our experience with octreotide in these things. But I think that this is, one real advantage of retroperitoneoscopic donor nephrectomy. Mobilization of, this has all been discussed. And as one situation for those who do retro donors, sometimes when you're using the renal angle port to clip, you're not able to reach the distal vein because your aorta or the psoas comes in the way. So one trick is to put the camera in the renal angle and put your wet clip through the middle port. And this allows you to go quite far down on the renal vein and clip the vein. So again, retroperitoneoscopy allows quick access and all these other advantages that we've discussed already. So as I said, anticipate problems and you can preempt them. Most technical challenges do occur, but in the vast majority of times, it's very rare that you have to convert because of them. You may have to convert because of anatomical or other physiological reasons, but usually not because of those. And just stick to technical details and you'll be fine. Thank you. And if you have sort of any questions or things that I've not covered, we can briefly talk about them now.
for discussion. Any questions? Yes, sir.
You said if there's a big grant, you can do like transperitoneal from behind.
Yes.
So can you do it intentionally? Suppose a big tumor where you're not getting space. In the beginning itself, open the peritoneum, push the kidney in the peritoneal cavity, put space, lift the kidney up.
You can imagine that just as well as me. I mean, it's not particularly pleasant doing this thing from back. You can do it, but because in this situation your kidney is still stuck to the colon, you're not able to get traction, counter traction between them. It's a bit difficult. So I haven't really thought about it. Perhaps you could do this. Do the clips from behind, open everything, drop it in. So like we were discussing early, in intentionally doing a two-phase thing in which you do vessels from behind and mobilization from the front. Potentially, I guess you could open everything up and do trans from behind. Interesting thought.
I'm Dr. Prashant, second year resident at ANU. Sir, since morning we discussed one or two times that our balloon dissection should not happen inside Gerota.
Yes.
It should be outside. So what are the technical tips? How will we make sure that our balloon is not inside Gerota while putting it inside? Sir?
Yeah, so the first thing is your whole first port placement is under vision. You've identified the lumbar dorsal fascia. You've made a small cut in that. You're seeing paranephric fat, the fat outside Gerota sliding up and down.
Yes.
So now you know your outside Gerota's fascia. So once you put a peanut in now and dissect a little space up and down, your balloon is certainly going to be extragerotal. And that almost never always goes intragerotal. Once in a while, if you get an infragerotal expansion, then you're going to see the capsule, you're going to have fat hanging up and down, and it just makes surgery a little more tedious. But this can usually be overcome by lifting fat, excising it, doing whatever needs to be done.
Thank you, sir.
So this hybrid approach of using the benefits of both retroperitoneal as well as the transperitoneal approach is actually described and there in literature. The SCPGI group, Dr. Anish Srivastava and Dr. Anil Mandani, they published their experience using this hybrid approach in T2 and above tumors.
All right.
And they actually said that this should be advocated in particularly large tumors where the hilum may be difficult to tackle from the
front.
From the front.
So this is right.
My question is: does the changing of the position, making a right lateral tilt or left lateral tilt, can also help in some cases, like we do in transperitoneal cases?
Sorry, what's the question? Changing the
tilt of the table, just in case the fat is hanging.
I don't think that would make a big difference. Hanging fat is going to hang, and you have to deal with it. You have to ablate it. I don't think, how much are you going to tilt it? Even 15, 20, 30 degrees, I don't really think. And then you'd be worried about the security of the patient on the table. You wouldn't want the patient sliding off. I do think that a patient in a lateral position strapped down is not quite as stable as a supine patient. And I would do a little tilting, but not too much.
So one thing is on the left side lap donor nephrectomy. Will the vein length be as good as what we get in a transperitoneal? Because in trans we can go beyond the aorta and do it. And
yeah.
One more thing is when Sir has been mentioned about the hybrid technique, in case if we can do the hybrid combination of retro followed by if we can retrieve the specimen to the trans, then we can avoid this inguinal and go away a phalangeal incision, where we can simply retract the rectus muscle and avoid muscle cutting.
Right. Your first question was about length. The length that one gets is just as good as trans because you dissect the vein down, you tilt it up, you're almost on the IVC. And once you apply your clips and cut them, you find that they retract actually out of sight. So length is never an issue. Coming to your second point about doing a retro procedure and then retrieving a trans, I don't really see the point of it. This, although there may be literature to support phalansteal, this muscle splitting incision in the iliac fossa is absolutely free of morbidity. So
maybe we can avoid the muscle cutting.
Then you're transgressing the peritoneal cavity. You're having bowel loops. Then you're going to have to open the peritoneum at some stage. You're going to have bowel herniating to the retroperitoneum. You just don't want to see any infraperitoneal structure. This is how I would see it. I mean, just to change your whole your approach to surgery just for the slight difference of incision, I think is probably not an advantage.
So we can mobilize the entire kidney to retro, thereby avoiding any injury to other organs, and retrieve it to the phalangeal. So
but why would you want to do all this? Just because you have a perception that phalangeal is a less morbid incision?
That's what we perceive actually.
See, I mean, this is from experience I can say that this groin incision has very little morbidity too. I just don't think there's any advantage to all this.
Retro for lower tract surgeries. I'm not aware, maybe, or like reimplantations, undescended testes.
So see, that would be, it would not be the retroperitoneoscopy we've been discussing all day. That would be extraperitoneal pelvic surgery, the type that you do for radical prostatectomies and other things. So that's a completely different kettle of fish altogether. It probably could be done for people who are routinely doing extraperitoneal, laparoscopic or robotic radical prostatectomies. They probably have a good orientation into dissecting the lower ureter, dissecting the bladder. I'm sure it could be done. But none of the kidney extraperitoneal work that I've done really gives me an insight into this. I'm sure it's doable.
Thank you, Dr. Jamal. This wonderful presentation. Absolutely great.
Thank you.
Along with the surgeries. Thank you so much. I now invite Dr. Vipin for the final presentation of the day. Management of the retroperitoneal space. Dr. Vipin, please. Can I invite Dr. Manikandan and Dr. Rishi Nair, please, to moderate?
I think Dr. Bipin, sir. Okay.
Even if the presentation is not there, the vote of thanks, you are the show person here, so you can just give your comments.
You can have mic and we can just discuss for 5 minutes.
So for all the presentations which I had already, Dr. Jamal would have covered up. Only one thing in doing partials, the Girota's anterior flap is there, that keeps on coming. So you can hold it with the Maryland, take it up and clip it with the anterior abdominal wall. So that whole area opens, and that you can proceed nicely with suturing. So that's the only additional thing I had to say actually. Rest of the things I demonstrated.
Sir, if we want to select any lab partial, which will be the best place initially, and which is the place we should avoid for a lab partial?
I am a left-hander. I will avoid right side lower pole anterior tumors.
Okay.
So because once you mobilize the kidney for the lower pole tumors, you have to mobilize the whole of the kidney. The right side, because there is no support. Left side you have adrenal holding it. So whole kidney further drops down inferiorly. The suturing becomes and the cutting also becomes difficult.
In case if you want to use a Satinsky instead of a bulldog, where would you place the Satinsky port?
So Satinsky actually I don't use. I use bulldogs only. I have never used actually laparoscopic Satinskys.
And then you do only arterial clamping or both?
Yes,
arterial vein?
Arterial clamping. Most of the times I think once or twice only I have put a clamp on vein.
Okay.
Otherwise it is arterial clamping.
Any other question?
I think, sir, it was an excellent session, entire day, retroperitoneoscopy we were doing, but many things we were doing wrong. So that we will correct. And for me personally, it was a very learning experience. And I think the vote of thanks we can have from.
Thank you. I will invite Dr. Chandrasekhar.
I hope Dr. Pippin will remember that he came to our institute in 2017-18 and he demonstrated to retroperitoneoscopy.
Yeah.
But it was again a thought block to start on my own only because there was difficulty or the thought block was in placing the port positions. placement post-position. But now I think
I hope you have
after
clarified my-
today's learning, things looks very comfortable and easy to go and start again.
Thank you so much.
Thank you.
I'll invite Dr. Chandrasekhar for a vote of thanks.
Thank you all for coming here on a Sunday. And at the end of the session, I hope you all enjoyed this scientific feast and operative feast by surgeries done by the masters. And as every session ends, I would like to give a note of thanks. Our main thanks to our chairman, Dr. Nageshwar Reddy sir, and our vice chairman, G.V. Rao sir, for giving us auditorium and at the same time allowing us to operate in theaters. And our operating faculty who have been here on a Sunday, Pranjal sir and Jamal sir, and all other faculty who have chaired the sessions and who are the speakers, and all the chairpersons. And I would like to thank even our anesthesia team who have been with us for the whole Sunday. And I would especially convey our thanks to Dr. Sunil Pandian sir and his team, and Dr. Dayakar, Dr. Sai, Dr. Vijay, and Dr. Neha who are there here. And I would like to even thank our OT staff who have spared us and who have been with us on this Sunday, and OT sisters, OT technicians, anesthesia technicians, and our OT manager, and all the GDAs who have been with us here on this Sunday, and all the sisters in the pre-op and post-op area, and the OPD staff and the residents. And I would also thank audiovisual team and Satyanarayan Garu and Mohan Garu, and our business development team, and the pharma and academic partners, Sun Pharma and Intas, and all the delegates who are with us on this Sunday. Thank you.